Hello to everybody and welcome to the first English Diabetes Footcare Network National Conference for 2021. My name is Richard Lee. I'm Consultant Podiatrist at the Royal Free Hospital and I chair the EDFN group. I'm very much looking forward to this afternoon's presentations, which I hope you'll find extremely interesting. But first, there are a few housekeeping matters that we need to go over. If you wish to ask questions, then there is a Q&A function on the right-hand side of your screen under the stage button. So please put any questions there. We will try to get through as many of those as possible. And if you want to chat, there is also a chat function for comments as well. If you have any technical issues during the event, please send an email to Emily Mayhew at the address you can see there. So without further ado, I think we can start the presentations. And I'm going to start really by telling you a little bit about the English Diabetes Footcare Network, how it came about, and why it exists, what we're trying to do with it. So I'm going to talk about the EDFN working to improve foot care in England. If I can have the next slide, please. So a little bit about us. Across England, there are 12 clinical networks, and these have been working up until 2019, really quite independently of each other. Wales, Scotland and Northern Ireland already had national networks which were all combined prior to 2019. And in England, we found that networks were contacting each other, sort of networking networks, if you like, to find out what each other were doing. And we found that we were all really trying to do very similar work. However, we were coming at it from slightly different angles. And in fact, all the districts were all trying to reinvent the same wheels. So the idea of the EDFN was really in linking these networks to provide joint benefits. So the EDFN was established in 2019, aiming to develop an English-wide network to produce a focus for strategic developments, share best practice, and advise relevant stakeholders, such as the Department of Health, NHS England, NHS Innovation, each of the networks, Diabetes UK, and so on all matters relating to service delivery and improvements in England for diabetes-related foot disease. Next slide, please. And one of the first areas we've tackled is looking at peer review. And this is a really useful tool in finding out where there are gaps within services or between services. And we asked the networks if they would kindly share any information they had on their own tool. 6 networks provided us with peer review questionnaires. And they, again, had very different approaches to this. Some of it depended really upon how much funding there was available to approach peer review. So some had very comprehensive questionnaires. Others had gone down what was called a peer-light approach, which was really a self-review, and the findings from that review could then be presented at network meetings and to STPs. The EDFN reviewed all of these questionnaires and combined them. The idea being that we would get the best sort of peer review we possibly could, but that it could be used in either format. So it could be used for formal visits from an external group, or it could be used for self-assessment and self-review in this sort of peer-light type of review. Next slide, please. So having combined them, you can see that it came up with quite a long list of questions, and all of these have been mapped out. What we're currently doing is trying to put these together in an online questionnaire to make it much easier for teams to generate the information that's required. and that's going to look something like the next slide, please. So here we are, and there will be peer reviews. There is one for secondary care, and there is one for community and primary care. And this data will not be collated centrally, so there's no worry about information sort of being shared in that way. This is really for use within the networks and within teams of either MDTs or for protection services. And really what we're trying to do with this is to establish a common set of questions across England, so that, again, people, if they wish to, can compare what is happening in their area with other areas. And networks may look at working with these at a higher level, if you like. The next slide, please. So we've started with peer reviews, but we also recognise that root cause analysis for non-traumatic amputation is also very important. Just to sort of define it, root cause analysis is a process to identify what happened, how it happened, and why it happened, and really to learn from anything that could be changed to improve patient outcomes. It should include all parts of the pathway, and as we know, that doesn't start when the patient first sees the surgeon. This goes back a long way, and it starts off with when the patient first noticed a problem with their foot, and it may be that there's been a delay in care and so on. So those are really important factors. It should chart the pathway all the way through and look for causal factors that led to amputation, and therefore finding the root cause. And from that, recommendations can be developed, and actions can be implemented, so that we continually learn of how to improve our services and our outcomes. Next slide, please. So in 2012, there was a root cause analysis of collected data on 124 patients from 30 hospitals across England. But there was very much a paucity of information gathered from primary care. Most of this information came from the point at which the patient had entered hospital. There's been no national root cause analysis data collected since 2012, as far as we're aware. And so again, we really don't understand where changes have been made and how that information could be shared so that we can all learn from it. Next slide, please. In London, we tried to implement a root cause analysis in 2016, limiting it to the last 5 patients who'd undergone a major amputation, realizing that this is quite an onerous task in the amount of information that was collated. We had response from 3 of the hub hospitals for vascular surgery, and 15 patients were reviewed. The audit was designed to cover all areas, so primary, secondary and community care, but it very much lacked information and data from primary and community. There were 2 sections to this audit. The first section, 24 questions, looked at the service itself, how the service was designed, and what sort of capacity it had and the staffing of it. And the second part, so section B of the audit, looked at 98 questions, everything from demographics, histories, procedures, investigations, and so on. Next slide, please. So from the previous RCA we did in London, we learnt that actually there were too many questions. And so we had another go in 2018. We reduced the template to 68 questions from 122. And we managed to review 71 patients from 9 hospitals. Trusts were asked to submit their databases on the first Monday of each quarter, and again containing patient demographics, patient factors, and so forth. Next slide, please. And the outcomes from these various root cause analysis have shown that the age range of patients having amputations is widening, patients presenting with gangrene have reduced, increased management of hypertension and ischemic heart disease. There's been increased number of patients with mental health needs, but interestingly, no impact on their presentation. 2/3 of patients were known to foot services. Access to multidisciplinary foot teams improved the outcomes. That delays were not always avoidable, and some patients did not see a healthcare provider prior to an A&E attendance and their amputation. Next slide, please. Thank you. So also we looked at what the reason behind people not completing RCAs really was, and the time is one of the problems, especially when we had over 100 questions. And so it is a time-consuming thing to do. Certainly a lack of resource, so who was responsible for completing each part of the pathway? And of course, one person really can't do that because you need information from across community, primary and secondary care. We all realise that there are issues with IT and a lack of data sharing, and multiple systems with multiple bits of evidence and record on them, and very difficult then to put together the background to what has happened to these people. Unfortunately, it hasn't been mandated, and certainly not until this point. And so really we're trying to find another way to do this, which will reduce the amount of input that has to be put in by clinicians themselves. And we found that central hub data collection was easier than tracking to primary care. Next slide, please. And so what we're proposing is a way of changing the way that we do this, because we can look at age of the patient and the demographics of the patient, how long have they had diabetes and so on. But actually, we've never really gone down what we've called a narrative pathway, which is to start with the patients, the care of the family themselves, and ask, when did this start? When did you first notice? And what was your journey? What was the patient journey like? We could certainly start to look at IT systems and how we might be able to pull data directly from primary and community care and also secondary care. But of course, as you can see in the green boxes there are many, many systems involved. I think there is work ongoing at the moment to develop an umbrella system which may be able to help with this, so that we can actually review records and data from the entire patient journey. And so as we get data from community and primary care, we can then have a narrative at that point. And again, in secondary care, have a hospital care narrative. And then we go into the sort of main part of the RCA by looking for causal factors, finding the root causes, formulating action plans, and then disseminating those findings so that we have an action plan locally and for commissioners. And indeed feeding some of those key learning points back to the clinical networks and into the EDFN so that we can share best practice and hopefully again improve patient outcomes from that point. Next slide, please. So we know that there are ongoing questions about multidisciplinary foot teams, and certainly from vascular surgery, the Get It Right First Time program, the Vascular Society produced a quality improvement framework. And the idea here was looking really at patients who had non-traumatic amputations who didn't have diabetes, and was there really a pathway for them? And one of the recommendations coming from the Vascular Society was a multidisciplinary lower limb team, and it said this model of care borrows from the one successfully implemented by multidisciplinary diabetic foot care teams. And we're going to have some discussion about that later this afternoon. Next slide, please. And also the GIRFT report regarding diabetes talks about having community-based foot care protection services for screening, and also multidisciplinary foot care services to reduce ulceration and amputation rates. It says that we found wide variation in the quality and coordination of these services across the country. In many areas, hospitals still do not have a fully established multidisciplinary foot service, and in some areas there is no foot protection service. And these have been recommended by the Diabetes GIRFT report. And I think that this will link to the vascular GIRFT report as well, in suggesting that actually multidisciplinary foot services should be trying to prevent all non-traumatic amputations. Next slide, please. So what the English Diabetes Foot Care Network is trying to do is to link all of this work together. Peer reviews, root cause analysis, NICE guidance, the long-term plan, get it right first time. I can add into that the National Diabetic Foot Audit, which we're also working to promote through the EDFN. And also there is due to be a publication by NHS Resolution, which is looking at reasons why people have gone on to have amputation, and recommendations will be made by NHS Resolution. And as soon as that is published, we will put that onto the English Diabetes Foot Care Network website. Next slide, please. We have also worked with the all parties parliamentary groups on venous and vascular disease and also diabetes. Back in the meeting on the 1st of December, from the discussion summary that was had in Parliament, said this event discussed the disparity in vascular care for patients with peripheral arterial disease without a diagnosis of diabetes compared to those with a diagnosis of diabetes. The importance of establishing a baseline of integrated vascular care through access to multidisciplinary foot care teams. And so I think that there is further scope for working across these groups and trying to make sure that we have fully implemented multidisciplinary foot services and foot protection services in every part of the country, and that we start to look at that provision for diabetes and possibly, as we'll discuss later, the implementation for people who don't have diabetes as well. Next slide, please. So other English Diabetes Foot Care Network work. Today is our first national conference, and it's wonderful to know that there are so many people who've registered for this today. We have put together a referral tool published to help teams recognise foot problems and warning signs called Act Now. If you go and you have a look at the poster hub, you'll find a poster relating to that. The network has released Foot Care Clinical Strategy for the second wave of COVID-19. We're calling for data about that as well. And foot care experts got together from Northern Ireland and gave a webinar for patients to promote self-management. The other work we've done with the EDFN has been looking at the National Diabetes Foot Care Audit and trying to promote that as much as possible, because again, this brings together national data that is hugely important for England in order to progress and make our services better. And the last slide, please. So the next steps, EDFN. We are going to complete the online self-assessment peer review tool. As I mentioned, that's going to be both for secondary care, there'll be one for that, and there'll be one for primary and community care. So please go to the EDFN website, keep an eye on that. They will be published very soon. The root cause analysis, we are going to try to devise the narrative context for the RCA, and again try to build a nationally available tool for that. We will continue to lobby for multidisciplinary foot services and foot protection services in England so that we have 100%. We will also continue to lobby for the right workforce to make sure that this is implemented properly. And we will continue to work with the all parties parliamentary groups, NHS England and so on, to reduce variation and implement the long-term plan and GIRFT. So I know that there are people who have registered for this afternoon for the conference who aren't signed up for the event yet. We are basically not just a group of podiatrists, but a group of multidisciplinary team members, and we really want anybody with an interest in non-traumatic amputations and reducing variation to come and join us. And that will help us to share best practice across the whole country. So thank you very much. I'm just going to see if there was anything in the Q&A. I've had a question from John Bridger that says, could summary care record data be used to obtain a full picture of primary care episode history for RCA? Many of caseloads now have expanded summary care records, but requires patient consent to access. I don't see why not, John, and I think that we're going to look at all areas that we can gain data from, and what we're going to try to do, the RCA, is to pull as much of that demographic information and sort of patient information that's already held on record and get that to upload automatically into the RCA, so that what we end up doing is really concentrating on the narrative parts. And I think that that will reduce the number of man hours required to input the data, because certainly trawling through patient records and filling in Excel spreadsheets, which is, I think, the classic way that these things have been designed, is actually, one of the blocks to getting RCA completed. So the easier that we can make it, I think the more likely it will become that RCAs will be completed. Also, I suppose there is the question of can you mandate it? I think that's more of a question for NHSE, and if they feel that that is completely necessary. And Alison Kerr has asked, will the presentation slides be available? We are probably going to put this onto, or link to this onto the EDFN website, so you should be able to find it there. Lovely, and I think that's all the questions I've had so far. So we're slightly ahead of time, but I think Graham Holt is with us. And Graham's going to talk about the role of foot protection during the pandemic. Graham is the professional operational lead for the North Manchester Podiatry and Leg Circulation Services, and as an advanced clinical practitioner. Graham chairs the Northwest Podiatry Services Clinical Effectiveness Group for Diabetes, Wound Care and Peripheral Arterial Disease, and is a representative for the Greater Manchester Diabetes Strategic Clinical Network. He's a member of the EDFN and chair of the Podiatry Apprenticeship Trailblazer Group. So thank you very much, Graham. Over to you.
Thank you, Richard. Good afternoon, everybody. So I only have 10 minutes, so I will press ahead with the slides, but it's an absolute privilege to be presenting today on the first EDFN network. Can we have the first slide, please? So I've been asked to talk today about our experiences as a foot protection and high-risk foot team in the community through COVID. And when it became clear that things were escalating, we started to prepare for a service change. So we started with prioritising our caseload. Most services have a service impact assessment where they look at things like being unable to access buildings or severe weather disruption. And this was where we started for our patients. And we focused mainly on our active ulcerated patients. We weren't quite sure what impact that these things were going to have on our caseload and our capacity. So we prioritised those at highest risk of amputation and infection and death. We thought about safe escalation processes. What would we need for patients to be able to approach us if they had a concern so that it could be addressed quickly and safely? And by looking at the caseload, it helped us look at what staff time we could free up and then what other services could we support through COVID when the ask came. We looked at planning redeployment, so how many staff would we have, what services would they go to, so that this would then give us some insight into the skills that we would need to support the other services. Next slide, please. And through this work, we came up with some very simple aims to help drive where we were going with this process. So the first one was to protect patients at highest risk of ulceration and death, to have a safe escalation process for patients developing problems, and support those patients with acute ingrowing toenails. And this was mainly just to prevent those patients from having to go to secondary care or not getting any care at all during this time. Next slide, please. So then we started looking at the implementation. So things at this point were moving very, very quickly. So we started to widen the service down, and this was cancelling and moving the appointments for every patient who wasn't ulcerated and was currently intact. And within 2 days, we had moved and cancelled 500 appointments and sent out hundreds of letters and made numerous phone calls. And then the staff were deployed to the integrated neighbourhood teams. So in most areas, they do have integrated neighbourhood teams made up of our district nurses, tissue viability from the active case managers. And it was to support these teams, the skills from which were being used to support other COVID efforts. We had a plan in place for the assessment of skills and training, and we knew exactly what we were going to do and what was going to happen to support those staff who were going out on redeployment. We arranged our timetables so that all members of staff would be in the podiatry team for at least 1 day a week. And this allowed us to support them just to make sure that professionally they could carry on with their skills. But also, if there were any difficulties, you know, we could provide that support and that peer support. And all this during a time when a lot of staff were extremely concerned. No one quite knew where we were up to with PPE at that point. No one knew exactly what the impact of COVID was going to be. Everyone was quite nervous about getting it, you know, physically, what was the impact going to be? What's the impact on our family and friends? At this point, we'd already gone into lockdown. So there was a huge amount of uncertainty. But we'd planned quite well for this and we were ready. And so we started implementation. However, next slide, please. Unfortunately, to begin with, things didn't go very well. Next slide, please. So what did go wrong? So unfortunately, there was no preparation from the integrated neighbourhood teams. We'd talked to the team managers and to the lead nurses at length about what we would need. And that was including assessing patient skills, assessing our staff skills, where they were up to, what was it exactly that they wanted us to do? Did they want us to support with doing insulin injections or compression therapy with wound care? And unfortunately, they didn't do any of the preparation that had been agreed. Then the teams were assigned inappropriate caseloads. So without any training, staff without compression training were sent out to see leg ulcers. We were sent out to see patients with catheterization. And these things, unfortunately, were highly inappropriate. There was also a random interpretation of COVID guidelines by some of the teams. There was one team who decided that they couldn't do joint visits with any service. So our staff were left sat in the office. And one of the big issues we faced was also a lack of understanding and respect for podiatrists. Despite working closely with many of our community teams, there was still unfortunately a perception that we did feet and nothing else. We didn't have the ability to drive those skills. for example, that we couldn't do insulin injections or learn that skill. So that was quite disappointing. So as a result of that, I recalled the team. On one hand, that was disappointing that unfortunately those things haven't gone well. But on the other hand, it was actually beneficial to the service. Next slide, please. Because then we were hit with the reality of COVID and what this meant to services. So one of the big impacts to begin with was staff absence. And at one point, for suspected COVID, because at this time swabbing wasn't happening on a regular basis, there was half of our team suspected of having COVID who were absent. And then we had shielding patients. Our pressure on home visits went up. At this point, shielding patients were being seen at home, and that put huge pressure on our home visit service. And then an increase in ulceration and re-ulceration. So we're still trying to assess the data on this, but the feeling was that patients who weren't getting treatment, who were intact, were then going on to develop callus and breaking down and ulcerating. So we saw a slight increase in the number of referrals for ulceration. And then we were asked to support the swabbing efforts to try and help manage COVID. So that was an additional pressure on the service. And we also had reduced access to acute teams. Particularly, we had some vascular issues. In one area, it worked quite well because we work across 2 vascular teams. And on the other one, we had significant pressures in trying to get patients in, because obviously they were conscious of the number of patients they were admitting. But unfortunately, we know of at least one patient. Unfortunately, his journey didn't go well, and we lost that individual. Next slide, please. And then things came together, and they came together really well. So our ulcer clinics were working well. We were seeing over 100 patients a week in our community ulcer clinics, and numerous home visits. The triage was working really well. So we'd instigated photographs, and we had new access to data sharing across EMIS and our other platforms. So we could fully see the patient's medical history, and the photographs gave us a real boost in being able to see exactly what the presentation was and assess it more effectively. We were supporting the swabbing with 2 staff full-time a week, but that was going really, really well. They were a big part of that team, and I think it helped open people's eyes about the skill and professionalism within podiatry. We were doing safe and well checks. So for those patients who were intact on home visits, we had a lot of vulnerable elderly patients who didn't have any other services going in and supporting them. So our staff who were self-isolating and shielding and not able to actually work in the service, they were phoning these patients on a regular basis, making sure they were really well, making sure they had food and signposting them if they didn't, and also checking whether they had any foot issues that might put them at risk. And at this point, we'd had good staff availability. Initially, we'd lost quite a lot, but at this point, we had most of the staff within the service. Next slide, please. Then we had PPE. This gave people reassurance. We had cleaning schedules in place. We freed up our MSK because we weren't running an MSK service. And this gave us, for the first time, to have some really meaningful MSK input into our high-risk foot and ulcer clinics, being able to think more effectively about how we offload these patients, how do we get them healed faster, how do we keep them healed. The shielding patients started going out and then coming back into clinic. And we were supporting the INTs, but this time from our own services and supporting their lower limb work. Next slide, please. And at this point as well, we started supporting NHS Nightingale Northwest. And this was initially for podiatry, wound care and arterial assessment. That developed quite quickly into supporting on all lower limb issues. So the way the teams were set up, there was tissue viability input into Nightingale. However, those teams didn't do anything on the lower limb. So as we developed competencies on leg ulcers, so we did everything from arterial assessment to leg ulcers. There were a few bone issues that we were leading on. And wound care and pressure ulcers was a particular problem that we're supporting with, and we did a lot of casting at that point. Next slide, please. And then there was calm. So lockdown started to ease, and the pressure on the staff started to reduce. The weather was really good at this point, and that helped people feel better. They were able to get out. The sun does help people's well-being. And we had some time for reflection. So we took a couple of days out with the entire service. We looked in detail at what went well, what didn't go well, what did we learn, how did people feel, and all this was escalated up from our organisation to see exactly, what we'd learned, and we really focused on well-being of the staff at this point. We'd learned a lot from it. Next slide, please. So things were seemingly settled. So we started having conversations about going to a full service restart in September. And we'd been given permission for this. And then within 2 days, we were told we had to step the service back down again. Next slide, please. Because then we were hit with lockdown 2.0. However, we'd learned a huge lesson from the first time round. And so our approach was very, very different. So we had some staff redeployed to support vaccinations, and we had additional support available if needed. But the focus this time was very different. So we continued with our ulcerated care for our patients who were at highest risk. But on this occasion, we focused as well on those patients who were still intact. So we ran a small service to try and prevent deterioration in those patients. And also we were aware that the home visit patients hadn't been seen, particularly those who were really elderly and vulnerable. And we really wanted to make sure that we got in to see those patients and make sure that they were safe and they were well. We once again supported with Nightingale. This time it wasn't COVID patients, it was all rehab. So our approach was slightly different this time. So we were trying to keep patients mobilized so they could go home as quickly as possible. We still supported on wound care. There was still a lot of pressure ulcers in there as well. Well, this time it was all with a very different feel. So there wasn't the uncertainty and the panic that came with the first lockdown. However, staff and the public in general were fatigued. It's still been a long COVID. People weren't getting away. They were still under pressure. So whilst in some respects it went quite well, we were still focused on the well-being of staff, and fatigue was a big issue. Next slide, please. So our takeaway lessons to date was staff well-being. This is the heart of everything I do. Without staff, we can't deliver our service. We focus very much on our patients, but without our staff to do that, and without well staff to do it, we can't do it well. We've been supporting COVID escalations. So focusing on those things like the vaccination program, and on those things alone that have the highest priorities. We were focusing also very much on appropriate patient self-care, and it gave us the opportunity as well to help drive this agenda. So patients who ordinarily wouldn't have cared for themselves were thinking very differently. They didn't want to go out of the house, or they didn't want to put pressure on the NHS, and they're very open to think differently about how they could do their own care. So manage their own skin or do their own wound care to reduce their visits. And we used materials like videos and information leaflets to support this. But we also become aware of the dangers of frailty. As we're a community service, we don't see a lot of inpatients, but Nightingale made us very aware very quickly that patients who aren't mobilised do develop frailty very, very quickly, and have now started projects with our neuro rehab team, how we keep our ulcerated patients more mobile to make sure that they don't develop frailty and lose things like muscle mass or the ability to walk and mobilise and things of that nature. Next slide, please. So adapting our practice for the future. So we've continued now with in-depth triage using photography and having more information available to us about the patient's medical history. That's made our triage more effective, and we have to see less patients face-to-face. We use video conferencing where appropriate, usually for MSK to help assess patients. An MSK presence for high risk, this has worked really well, so we're going to continue with that and try to heal and offload our patients faster and more effectively. Next slide, please. And that's it. So those are our big takeaway lessons. It just remains for me to say a huge thank you to our team and to all podiatry teams who I know have done amazing work across COVID, and I'm happy to take any questions.
Thank you very much, Graham. I think you've probably talked through the findings of a lot of areas around the country, and certainly speaking for London, the South East, we had a discussion around COVID and what had happened, and I think findings are very, very similar. One of the questions that's come through is, have your amputation rates gone up throughout this time?
So the answer at the moment is we're not sure. We're still working with our vascular teams. At the moment, we are doing some work citywide on the vascular service and how that looks. But there's also been some changes organisationally, so it's not easy to get hold of that data. But we are working with Nasir Ahmed, who drives the Manchester Amputation Reduction Strategy work, to have a look at that over the coming months.
That's great. Thank you very much indeed, Graham.
Very welcome.
So what I'm going to do is, we've heard about the experiences from Manchester. So as I mentioned, we had some discussions in London and the South East as well about experiences from the podiatry front line during COVID-19. And so I'm going to talk a little bit about that. Next slide, please. So during the first wave in London and South East, within the clinics, we had services had concentrated on active ulceration patients only, and cancelled a lot of the non-urgent cases. Now, this caused issues with administration because many of the community clinics had their clinics booked 8 weeks in advance, and you can imagine the numbers of patients who had to be cancelled or rescheduled. In the clinics, we had to adopt social distancing. This increased time between appointments, but also decreased the capacity that was available. A lot of clinics implemented telephone clinics just to check on high-risk patients who'd not been reviewed in clinic and to make sure that either their feet were intact or if they had a problem that they were seen as quickly as possible. Admin areas had to be screened off, and many places introduced one-way systems so that patients weren't left waiting in waiting rooms sat next to each other. Patients coming into clinics had symptom questionnaires and temperature checks before they were allowed into clinic, and any symptoms they were asked to go away and isolate. And of course, very early on in the first wave, we didn't have access to things like PCR and lateral flow, and so it was really a symptom-based position we were in. Some areas had car parks, and they were able to say to the patients, please stay in your car until we phone you to come into the clinic. And in many areas, hospital transport was limited. And that was partly because, of course, ambulance crews themselves were having to isolate. Many clinics started to employ virtual clinic. And I think very much, as Graham mentioned earlier on, we were using things like Attend Anywhere and Pando. And Pando really to keep the teams linked together. And home visits were implemented. So a lot of areas, clinics were closed because they were turned into COVID hubs in community. Next slide, please. So for the patients, there was definitely a reduction in health-seeking behaviour. And many patients didn't want to travel. They didn't want to go anywhere near a hospital or a clinic. And of course, on the news, there was reports that people with comorbidities were more susceptible to COVID. And I think it scared a lot of people who didn't have a really acute episode or problem. In some areas, patients didn't realise the hospitals were open because all their other outpatient appointments had been cancelled. Anecdotally, some patients' foot ulcers seemed to do really rather well, and that may be because they were isolating at home and not putting pressure through their feet. And there was a question actually earlier on to say yes, had our amputation rates gone up? I don't know that either, and we're looking at that at the moment. But it appears that there were some patients who certainly presented late to clinic and required admission to hospital. And we were also concerned about the mental health of our patient cohort because the worry about ending up in hospital with COVID was certainly there, but also the isolation from self-isolating. Next slide, please. And when it came to clinical concerns, In the first wave, community teams were having difficulty accessing PPE. And as Graham mentioned, there was secondment of podiatrists to proning teams and other COVID-19 services. And also there was a lack of staff at some points because, again, we weren't able to swab anybody. That wasn't available unless you were admitted to hospital. So people were off for 14 days, and that created shortages within the team. There were concerns about staff mental health and well-being, and a lot of trusts set up areas for staff to basically decompress, clinical psychology sessions and so on. Access to antibiotics and other medication were an issue where podiatrists couldn't prescribe. And I think that's really shown how useful independent prescribing is within podiatry in getting access, not just to things like antibiotics. I know that some areas have set up intravenous services and things like this. There was a loss of elective surgery, in particular vascular services, and I think a lot of podiatrists felt very alone. It was only when those services weren't there, really, that we found that how important the multidisciplinary team is and how much we rely on each other. As I mentioned, there was a loss of community foot protection teams as clinics were taken over to accommodate these community COVID hubs, and loss of capacity, partly due to clinic closures, partly due to home visiting and social distancing in clinic. And I've already mentioned late presentations, so we had an increase in the number of acute foot admissions with severe pathology after the first wave. It was suggested that there was an increased burden of avoidable severe foot pathology, which then put further pressure onto MDTs. So those surgeons who'd been seconded onto the wards, those podiatrists who had been working often in limited conditions with few staff, suddenly found they had a lot of more work to do after the first wave. There were questions around COVID toe. What is it? Should the patient self-isolate? And also some services, community services, wouldn't allow step down of stable ulceration because they said they weren't commissioned to do that. Next slide, please. So COVID toe, a little bit about it. Can occur at any age, but mostly in the young. Very many patients are asymptomatic for COVID, and it shows up as a perniosis-like condition with types of chilblains, discoloration and swelling of the feet or hands, with blistering, itching and pain, and areas of rough skin. On the whole, these COVID toes tend to resolve within 14 days, but I've certainly seen patients who've had them for 3 months or more. Treatment is really to alleviate symptoms using hydrocortisones, and the full pathophysiology of this isn't fully understood, but certainly localized lymphatic vasculitis has been demonstrated where there is presence of COVID-19 in the tissue. And it's been suggested that interferon-1 is the likely candidate for triggering the condition, of which you find there are high rates in the young, and therefore they tend to be asymptomatic, but the interferon-1 actually causes this vasculitis. Whereas in older people, it may be that there's a slower response or less of a response from interferon-1, and hence there are further complications of COVID within that patient cohort. Next slide, please. So here we are. So high levels of interferon-1 being produced, interferon-1 preventing viral replication, but leading to these types of lesions. And next slide, please. So we know that podiatrists were redeployed in some areas to proning teams, to wound care, and in many areas they were able to reduce multiple visits by themselves and the district nurse and the GP by actually supplying medication and reviewing non-foot wounds. They use their independent prescribing, both on wards and in community, and implemented IV drug therapy. And they were able to rapidly change their work patterns to enable virtual reviews. Next slide, please. So very early on, we didn't have a lot of guidance, and certainly in London, we came up with a clinical strategy for services for managing diabetic foot ulcers during COVID-19. This was matched by national guidance from FD UK, and I think in a lot of areas, certainly we took all of this and created our own local version. And I know that there were several of these in London, so that we had some defined pathways to work with. And what this tended to do was concentrate on those with acute foot issues, and to try to get those patients who were isolating at home, or those who were able to attend community clinics where they still existed, those more stable patients were being treated there. That then increased the capacity within secondary care, and also made sure that we were looking after the most needy of the patient group. Unfortunately, that then pushed a lot of patients onto waiting lists who had intact feet, but again, telephone appointments were made to ask if they'd had any problems, if they're having problems, and to ensure they knew who to contact and where to go if such problems occurred. Next slide, please. So after the first wave, getting patients back to clinics, trying to improve their health-seeking behaviour was difficult. I think there was less of an issue with this in the second wave. I think patients had become more used to being out and about and were a little happier, especially as people were told they needed to wear masks on public transport, social distance and so on. So we didn't see the same rate of cancellations in the second wave as the first. We tried to reduce home visits where possible, and certainly community clinics, some of them were able to reopen, but of course we then, as Graham mentioned earlier, went into the position of having vaccination centres being set up in the places that had previously been COVID hubs. So not all teams were able to go back, and a lot of home visits continued. By the second wave, there was enough PPE, thankfully, to go around, and we were still dealing with a lack of capacity caused by social distancing and staggering appointments. So there was still a move to treat those who had the greatest need. By this point, we'd already created one-way flows through clinics, and that had been maintained. That really didn't change between the first and second wave. We had engaged IT and information governance for virtual clinics, and certainly in my own trust, we had been trying to do this for some time. When COVID hit, it was all up and running within a week. So some very useful tools came from this. And in the second wave, there was a lack of how to restart guidance. And I think a lot of places were continuing with what had happened during the first wave, because there was no real direction as to how to start up again. Next slide, please. And so, indeed, the English Diabetes Footcare Network published a clinical strategy for service management of foot care during phase 2, the second wave of the COVID pandemic, in September. And that was published both on the EDFN website, but also in the Diabetic Foot Journal. And that really discussed how to restart, but also strategies moving forward that various areas had found very useful. Next slide, please. And at the Royal Free Hospital, we had a look at auditing our patient data from those patients who admitted, and we looked at the top 8 diagnoses for podiatry treatment and compared 2019 to 2020 data. And the outcome showed a spike of cases from May 2020 for inpatients, which hadn't been seen in the previous year. Interestingly, the top 6 diagnosis categories were identical in each year, so we didn't see a shift to a different type of pathology. Next slide, please. And if you can click again. There we are. So here we are. At the top, we have the data from 2019, and below it, the data from 2020. And if we can have the next slide, please. I think you can see it slightly better with these slides. And in the lower graph, you can see that big red spike from May into June. And those were really quite severe foot conditions that were being seen on the ward. Lovely. And next slide, please. So during these periods, we found new ways of working. We'd found virtual video clinics especially useful, in particular in care homes, but also in supporting community colleagues, both in clinics and in home visits. And there were certain things like wound matrix, which certain teams have been using in the southeast. Podiatry hot clinics were set up, often where no service such as that existed before. And some areas actually conjoined teams with a podiatry, a vascular and a tissue viability nurse in order to create a sort of multidisciplinary foot hot clinic or lower limb hot clinic. Patients who had extended their return dates didn't appear to have caused major problems, so there may be an opportunity to reduce clinic visits in the future. And we also saw the extended role of the podiatrist, both in the COVID-19 teams and working with them, in home visits to help district nursing and reduce visits to the patient's home, and in independent prescribing and reducing the need for further visits to the doctor. And the next slide, please. And so, as I mentioned earlier, we are collating any data from the first wave, or we're not quite out of the second wave, but if you have any data, then please do forward it to the EDFN, because we are trying to look at what happens nationally with teams and what we can learn and best practice from that. Thank you very much. I've had one question, which is, what treatment did you recommend for COVID toe? And it really was the symptomatic side. And so look at using hydrocortisones to deal with the symptoms for that. Hello and welcome back. We are now going to a session of abstracts, some presentations. We asked for people to submit abstracts, some of which you'll be able to see in the poster hub. But there are going to be 4 presentations, and we're starting with a presentation by Jennifer Williams. Jennifer currently has 2 roles, firstly leading the diabetic foot team in Torbay and South Devon, and also in completing a part-time NIHR-funded pre-doctoral clinical academic research fellowship with the University of Plymouth. Her research interests aim to explore the impact that promoting and encouraging higher patient activation levels can have on the management of diabetes and the prevention of foot ulceration. Over to you, Jennifer.
Thank you, Richard. Good afternoon. I'm hoping that they're going to share my presentation. I can't see it at the moment.
Yeah, it's on.
Oh, is it? Oh, okay. I've got a bit of a lag on my end. So I'll just use my paper notes as well. Okay. So my name's Jen Williams. I'm a podiatrist at Torbay and South Devon NHS Trust, and I am going to talk to you today about diabetes foot care education and are our patients at Torbay retaining that information. I'd like to just thank my co-authors, Richard Collins and Dr. Joanne Payton from Plymouth University. Next slide, please. So preventing diabetic foot ulceration is quite a key point. The International Working Group for the Diabetic Foot recommend that education is a key cornerstone of preventing ulceration. And the main factors that they indicate would be useful for preventing this are seeking help in a timely manner, understanding what the patient is looking for when they're looking at their feet, undergoing preventative self-care measures at home, including routine foot checks and foot hygiene, and knowing what they're looking for, and also things like their footwear, what sort of footwear they should be wearing and how often, and when and where they should be seeking help. Next slide, please. The NICE guidelines in the UK back this up further by asking for friends and family to be involved in the information provision, and that it should be provided in an oral and written format. The patient should also be aware of their risk status as by from their assessment by NICE, and they should get diabetes information. Next slide, please. In terms of the current practice here at Torbay, we do provide written and verbal education. There's two examples of the type of paperwork that we give to the patients below. They are given out at assessment and at review. And if the needs of the patient change, all of this information that the patient provided is appropriate for their diabetic risk status. Next slide, please. But as often we will see, the patients will complain that the information they're given, they'll just add it to the poll they already have. They don't really read it. So we wanted to look at other ways in which we could educate them. Next slide, please. So how do we do this? We decided to open a quality improvement project, and with the aim to seeing what they retain from what we told them previously. And to do this, we developed a questionnaire which contained 3 main sections. The first section was diabetes awareness and the type of foot complications that can result from that. The second was their day-to-day foot self-care that they should be practicing at home, and what the emergency escalation procedures were. So what should they do if they find a new wound, or if they've got a wound that develops an infection. Next slide, please. We looked to our entire patient group. They all had to be diabetic, and we covered this across all the clinics within our location. We didn't exclude any risk status levels, so we made sure that we covered low to active foot, but they'd all previously received education from the department and were all had regular foot care with us. The patients were approached to complete the questionnaire in clinic by the clinicians, so it was convenient sampling, and it took place over a 4-month period. During that time, we managed to sample about 5% of our current caseload. Next slide, please. So in terms of the information we got back, the 13% of our patients were able to define their HbA1c, which is a key education point for NICE. And about a quarter were able to define sensory neuropathy and peripheral arterial disease, which is interesting, as the majority of our patients will have one or both of these conditions, and they were unable to define it. Next slide, please. In terms of their day-to-day foot self-care, quite a good proportion were able to recall their footwear advice in terms of style and how often they had to check their feet, their footwear. However, quite a small number were able to correctly recall that they were meant to use their orthotic footwear indoors. Next slide, please. In terms of self-escalation or emergency escalation processes, 24% knew that they should seek help from the podiatry department if they developed a new ulcer. Now, these were all patients that are registered with us already, so all they had to do was phone and make an appointment if they had a new ulcer. 35% were able to recall what they had to do if they suspected they had sepsis. And these are bits of key information that we give to the patient every single time we see them. So we would expect those figures to be much higher. And 53% would be able to, could recall what they were meant to do if they found a new wound in terms of their own care at home. Next slide, please. So we looked at the management of new wounds at home. So patients discovered a new wound. What do they do with it? The advice would be to put a clean, dry dressing on it and phone the department. When we broke this down into the different risk factors, it became apparent that the higher up the risk factor indices the patient went, the less likely they were to recall that knowledge. And obviously, as they go through high and active foot risk levels, they are actually much more likely to develop a wound, but they were less likely to recall that advice. Next slide, please. So what were our key findings? There were some really good things that came back from our patients. However, they had some limited recall, particularly medical terminology. They were unable to define medical terminology, and the importance of their orthotic footwear and when they should be wearing that was something that they really didn't take on board. And SOS procedures are some of the really key information that we would want them to really take on board and to put into practice in the future were some of the things that they weren't recalling, especially things like they would phone the GP and wait for a GP appointment rather than phone in podiatry if they developed a new wound. Next slide, please. So what did we do next? We sat down with a group of patients, and they were all high or active risk diabetic foot patients, and we had a focus group session with them, and we analysed the themes that came out of that session. And the two main ones that I'm going to talk to you about today were education strategies that they talked about, and as well as the written and the verbal advice, they really advocated video guides and visual aids. They found that really beneficial to their learning. And a lot of them were quite switched on to electronic aids like apps and social media. Some had developed their own spreadsheets and things like that. So really interactive aids to help them learn. And a topic that came up repeatedly throughout the focus group was the difficulty they had in maintaining their motivation and their engagement with their own self-care needs, with the burden of the diabetes as a disease. Next slide, please. So from there, what did we do next? So we developed a series of short videos in association with health and care videos run by Health and Care Innovations. And they're no more than 5 minutes, and they deal with a lot of different topics. And we have some that are aimed at healthcare professionals, but a lot of them are aimed purely at our patients. And it's simple things like how to look after your feet or what to do with your diabetic foot ulcer. And they're all of it available on our external website for the trust, and the link is there. But we also have tablets in clinic. So if we want the patient to watch one of these videos in clinic, they can watch it. They are also able to take away QR codes, so they can upload it and access it from a mobile phone or something like that. Next slide, please. And in the last 6 months, we've actually developed a diabetic foot app. This is part of a larger app that's been developed within the trust called Connect Plus, and we have a diabetic foot section. The majority of it is information for patients, so it will have all the information that we would normally contain in our patient information leaflets is now stored in one app. They have access to all the videos. They're able to see all the clinic locations and quickly access links to the admin team so they can book and change appointments. They're able to see all the clinicians that would be involved in their care. Now, this is phase 1, and we actually launched that at the beginning of May. So that's live in the App Store now. Phase 2 is currently under planning, and this is planned to be a much more interactive app. So the patients will be able to store their medications lists, look at storing their blood glucose results, things like counting their steps, food diaries, so that they can really plan their care and be much more interactive with us. Next slide, please. I think that's the end of, there is another slide. I think it's the end of the presentation though. So I just want to say thank you very much to my supervisory team for my research, Joanne Payton and Richard Collins, all the patients and podiatry team at Torbay that took part in the questionnaire, and the app team at HCI plus Denise Walker and Sue Stewart, who were heavily involved in developing that. And just to say that, my research is funded by the NIHR. Thank you very much.
Lovely, thank you very much, Jennifer. I've had one question for you from Martin Fox to say, when NICE says we need to discuss a person's foot risk status to support their choices and decisions, what do we mean by risk? Risk of ulcers, amputations, or early associated death, or possibly all three?
It's a nice talk about there. To be honest, the education that NICE recommend is quite vague within the NICE guidelines. Actually, they don't really say what you should cover, but they do say that the patient should be aware of their risk factor and risk factors. So in terms of the NICE guidelines, that is, are they a low risk, moderate risk, high risk, or do they have an active foot problem? And they should be aware of that risk factor, that risk status, and the factors that have led you to make that decision. But in terms of holistic management of patients, that assessment is very foot based, and we should be looking potentially at more holistic management throughout the whole of the patient.
Lovely, thank you very much.
Thank you.
And we move on to our next presentation from Jane Robbie. Jane is a specialist podiatrist working in the MDT at Queen Elizabeth Hospital in Birmingham, and senior lecturer at Birmingham City University, teaching on their online MSc program in advanced diabetes care. Jane is also an active member of the Ideal MDT panel and a Diabetes UK clinical champion.
Thank you to the previous speaker and to EDFN for inviting me to present to you today on the results of an audit I conducted on mortality in people with diabetes attending a hot foot clinic during the COVID-19 pandemic. My name is Jane Robbie and I'm a senior podiatrist at the Queen Elizabeth Hospital in Birmingham and senior lecturer at Birmingham City University. I'm also a Diabetes UK clinical champion. We are all only too familiar with the data in this slide from my colleague Professor Mike Edmonds, which illustrates that infection of both soft tissue and or bone is common across all types of ulceration, often spreading rapidly through the foot and resulting in major tissue destruction. The signs of a red hot swollen foot should not be overlooked, as the progression from an initial minor injury to an unsalvageable tissue necrosis and overt gangrene can take as little as 48 hours. Diabetes is the most common cause of non-traumatic limb amputation, with diabetic foot ulcers preceding more than 80% of amputations in people with diabetes. So the COVID-19 pandemic caused major disruption to hospital services, including podiatry and vascular services. The redeployment of staff, cancelled clinics and postponed appointments resulted in delays to both assessment and treatment for many patients. So an innovative daily multidisciplinary hot clinic was initiated in my trust to reduce hospital admissions and provide a one-stop shop for patients with diabetes and other vascular problems presenting in an acute state. The clinic ran for 7 days a week during the first COVID lockdown from March to June 2020. And this audit was conducted to capture the outcome for these patients. So there were 226 attendances in a total of 173 patients. The total cohort was 72% male, and 39% of those patients were aged between 71 and 80 years of age. And this slide shows the diagnoses at presentation for some of the patients. So the majority of patients came in with problems like critical limb ischemia, claudication and rest pain. They had tissue loss and or abscess or infection. And a lot of them had ischemic claudication, as I've already said, and rest pain. So this shows some of the interventions that were done in this clinic for this cohort of patients, and this is for the whole cohort. We found that 15% of the people attending this clinic were directly admitted into hospital. So this slide then dives deeper and looks at the people with diabetes attending this vascular hot clinic. So of the 173 patients, 38 people died within a year of that clinic, which constitutes a 22% mortality. Mortality rates after diabetic foot ulceration and amputation are high, with up to 70% of people dying within 5 years from the literature, and those having an amputation have a mortality rate of around 50% within 2 years of that amputation. This high mortality rate is believed to be associated with cardiovascular disease and emphasises the importance of good diabetes and cardiovascular risk management. So of this cohort, 66 people had a diagnosis of diabetes at presentation, which is 32% of the original cohort. And 15 of the people with diabetes died within a year, and this represents a mortality rate of nearly 40%. The cause of death wasn't recorded for all patients. However, when I had a look at the hospital records, we found that 2% of these people died of COVID. 60% of the mortality rate had some respiratory component. We had 1 died after a major amputation, 2 of cancer, 3 of sepsis, and 1 of STEMI. The time after initial clinic appointment to death ranged from 0 to 7 months. So in conclusion, there was a greater than 2-fold increase of mortality in diabetic foot ulcer patients compared to non-ulcerated diabetic patients. And this is regardless of age, type and duration of diabetes, treatment of diabetes, or history of lower extremity amputation. And there appeared to be no significant link with cigarette use. Professor Mike Edmonds' team have previously suggested that heart disease has long been recognised as an increased risk factor for individuals with diabetes. However, this didn't seem to be the case in our cohort, as the majority of people had some respiratory component to their mortality. So we know that diabetic foot ulceration is associated with increased risk of all-cause mortality. And this innovative one-stop shop MDT clinic provided early intervention for patients with acute diabetic complications during the COVID-19 pandemic. It enabled resilient safety netting for high-risk patients. However, this mortality rate demonstrates the need for continued face-to-face clinics for this vulnerable cohort. This audit determines that delays not only result in poor morbidity in terms of wound healing and need for further surgery, but also in high mortality, which may be prevented with earlier intervention to prevent foot ulceration and modify cardiovascular risk factors. Thank you very much.
That was lovely. Thank you very much, Jane. A very interesting presentation, and I think it's an area that we could certainly do with more information about why and is it due to comorbidities and so on, and what can we do. And I think that follows the line we were talking about earlier about holistic care and actually looking after the cardiovascular side of these patients. I've had a question. I don't know if Jane's online.
Yes, I'm here.
You are there. Lovely.
Yes.
So the question is, who leads on reviewing cardiovascular risk management and ensuring it's gold standard for people attending MDT hot clinics in view of the high mortality rates?
So I don't think we had actually a lead person. We had primary care were enabled to refer directly into us. So we were able to take immediate referrals via podiatry colleagues in the community or GPs. We were able to take ward referrals, and because we ran the clinic 7 days a week, every day, we were able to see people within 24 hours. So nobody had to wait a significant period of time. So I'm not sure if that sort of clarifies what the question was about, but I don't think there was actually a sort of lead person. The vascular team did triage the patients to make sure that they were suitable for the vascular clinic, and we saw anybody who had a vascular diagnosis, whether they were diabetic or not.
So very much a holistic approach for all limbs at risk, really.
Absolutely, yes, absolutely. And in that big cohort, the 173 patients, we saw people with abdominal aortic aneurysms, we saw people with carotid disease as well. So it wasn't just foot that we saw, although it was predominantly foot problems. And certainly from a podiatry point of view, that was what I was there to see.
Fabulous. That was from Martin Fox, and I've also had a question from Andrew Patterson saying, are you saying there may be a stronger link with respiratory rather than heart?
So certainly for our cohort, I know that some of the data that came out from colleagues at King's had said that it was about cardiovascular risk, but in the cohort that we had, and particularly in those people with diabetes, the majority of the patients' cause of death that I was able to identify from their medical records had some respiratory component. So pneumonias and chest infections were quite predominant. As I said, 2 people had COVID and succumbed as a result of that. So it was predominantly respiratory, our cause of death.
Lovely. Thank you very much for that presentation, Jane. Thank you.
Thank you very much.
And we're now moving on to a presentation from Fiona Main. Fiona is an advanced practice podiatrist in diabetes in NHS England, and in 2017 became a Diabetes UK clinical champion. She's passionate about making a difference to patients living with diabetes foot disease and recognises the importance of teamwork to achieve her ambition. She's interested in telehealth, and that led to a coordinator role in research, and is now integrating a new service pathway enhanced by technology enables care to ensure time access to MDT foot teams to achieve faster wound healing with a potential to reduce amputations. Over to you, Fiona.
Okay, thank you very much. Could I have my first slide, please? Yeah, so this is a service evaluation study regarding remote management of diabetes foot disease enhanced by technology. The research was started actually in 2015, and as Richard has said, that we're now integrating that service pathway just now, but this study was done a couple of years ago. Can I have the next slide, please? So diabetes foot disease is just one of the challenges. Diabetes foot ulceration significantly impacts a patient's quality of life, leading to lower limb amputation in up to 20% of cases, with associated healthcare costs. Can I have the next slide, please? So as you can see, here is a map of Scotland. NHS Highland is in the bold yellow colour, and as you can see, it's a vast region, remote and rural, and it's bigger than the size of Wales. And where you can see the cross, this is Regmore Hospital, and that's where the Diabetes Foot Team is based, in Inverness, the capital of the Highlands. So delivering a diabetes foot service is challenging, but also for patients accessing specialist services is also challenging, because they have long travel distances, they have associated costs, and often they have to take a full day out of their schedule, their working routine, to attend for one appointment. Evidence suggests that 80% of major amputations may be preventable. However, early access to multidisciplinary foot teams are associated with a reduction in amputation. In the Scottish Highlands, local audits highlighted that more than half of patients who subsequently underwent an amputation were unknown or had presented late to the diabetes specialist podiatrist for the multidisciplinary foot team. Can I have the next slide, please? So the aims of this pilot study then, we wanted to create a new service pathway enhanced by technology to connect patients from rural locations to the central team in Inverness. So patients who presented with a diabetes foot ulcer who were reviewed by community podiatry, we were connecting them to the team. So how did we achieve this? The methods: community podiatrists reviewed patients with diabetes foot ulceration over a 6-month period using technology-enabled care. So the podiatrists have what is called a technology toolkit, and this consists of a tablet or an iPad to take images of the foot ulceration. And together with direct access software, they were able to email these images to a generic mailbox immediately, and also they were able to access clinical systems remotely. The generic mailbox is checked by the diabetes specialist podiatrist on a daily basis, so the referrals can be triaged within 24 hours, with an option of either calling the patient in for a face-to-face appointment with the foot team, or coordinating a video consultation with the foot team. There was also an opportunity to escalate any foot concern to the vascular team, or gain advice from the diabetologists. Or a fourth option was that the community teams would continue to manage the patients with remote support and access from the diabetes specialist podiatrists. So they also had an OmniRouter hub, which is a piece of equipment that would provide a safe and secure connection to deliver the video consultations using the Attend Anywhere platform. And additionally, we also collected data on ulcer duration, ulcer healing time, amputations, and patient experience. Can I have the next slide, please? So this is just a photo of myself in the podiatry clinic in the Diabetes Institute, which is in the grounds of Redmore Hospital. And I think it's really important to, we recognise that this is a complex disease. Patients and people are complex. So this is me connecting to my community colleague podiatrist in Fort William. So Fort William is 65 miles southwest of Inverness, and it takes about an hour and a half each way to travel. So Carrie, my community podiatrist colleague, she is in a patient's home. So we are still in this model of care, we're still able to provide face-to-face contact with the patient. So wound care has been carried out, debridement can be carried out. Many of our podiatrists in the remote and rural region are independent prescribers. So this is an example of video consultation, but we can connect straight into the multidisciplinary foot team as well and get advice from a diabetologist if that is required. So the results of the study then, 31 patients were referred for specialist advice using the pathway, and a total of 55 foot ulcers. Following triage, 110 community-based podiatry visits, including 45 successful video consultations, occurred with the multidisciplinary team. A total of 89% of ulcers healed, improved, or remained in a stable condition. 7% of the foot ulcers deteriorated, and only 3.6% of these foot ulcers experienced minor amputations. There were no major amputations. There was also a high satisfaction level reported by patients using the new service pathway and also on the use of technology. Can I have the final slide, please? So in conclusion then, the new service pathway and the technology solution has confirmed that diabetes foot ulceration can be triaged within 24 hours, ensuring timely access to a specialist foot team with the potential to reduce amputation and associated healthcare costs. And I think teamwork enhanced by technology has really been key to the success of this study. So on that note, I would just like to say a huge thank you to the Diabetes Foot team, to the research team, and also to the principal investigator, Professor Sandra McCrory, for your ongoing support and for making this study possible. Thank you very much.
Thank you very much, Fiona. I'd love to ask, you showed Attend Anywhere being used with your colleagues in community. Are patients able to access that system themselves in Scotland?
I think that they're able to access the system possibly in Glasgow. I know that they've used Attend Anywhere with the patient at home and the podiatrist in the clinic. But up in Highland in this study, we've always had the community podiatrists with them just to facilitate the technology side of things.
Yeah, it's a fantastic way of being able to get an MDT at home, really.
Yes, absolutely. It's really, I think it's got a lot of potential for the future. So.
Super. And are you intending to carry on the study to see what the benefits are further from that?
Yes, we've currently got 4 technology toolkits, as we call them, out in the community. So they're based in different areas, but we're soon going to have 5 more toolkits. So it's, we can reach out further to patients and also to nursing teams as well.
Lovely. Thank you so much, Fiona. That was absolutely fascinating. I think it's an area that needs expanding even further, and we can all learn from that. Thank you very much.
Thank you very much.
And the next presentation is from Paula Yates. Paula is Operational and Professional Lead for Pennine Acute Hospitals Trust. And at the time of this study, there were 4 hospitals. There are now 3, which are part of Northern Care Alliance. Over to you, Paula.
Okay, hello. This is just quite a short study on the Meeting the NICE inpatient foot guidance with no additional funding. Now, I'm assuming because it's a diabetes foot conference that everybody's aware of the NICE guidance that was set in 2012, where we were expected to assess all patients with diabetes when they came into hospital to hopefully prevent them from getting a foot ulcer, and also to identify whether they had a foot ulcer and refer them to the correct team within a space of time. So firstly, I'd like to thank my co-authors, which is Khadija, who's a podiatry colleague, and Dr. Susanna Rolls, who's a consultant physician. So the scale of our problem, as I said, it was 4 hospitals at the time. So it was an acute trust with 4 hospital sites, all between 7 and 10 miles apart. In total, we had about close to 1,500 beds. And looking at the data from Nadia of the number of patients you'd expect to have diabetes and the trust data of the number of admissions, we would have expected 50 people per day with diabetes to be admitted every single day, 7 days a week, spread out over the entire trust, not all isolated to the diabetes wards. So it was quite a large task. We had 6.8 whole-time equivalent podiatrists, and they were essentially there to treat the active foot disease as both inpatients and outpatients. So there was limited time left to actually do much else. So in 2012, we introduced a pathway. We audited that, and we weren't getting very far. And AQUA, which is a local audit where they audit a random selection of the diabetes patients admitted against certain criteria, one of which was a foot inspection and one of which was the length of time it took, whether they were seen by a podiatrist while they were in. Those and the data from Nadia both concurred that we were actually missing about 25% of all foot ulcers we never saw at all, and that we were only seeing about 30% of the there was only a recorded foot inspection on about 30% of those patients. So we set about trying to launch tests. We were already working with the pressure ulcer improvement panel, trying to work on collaborating on a document with the nurses to see if there was something that we could do to actually identify these patients sooner and get them to where we were. As part of that, and then part of the Royal College of Physicians QI project I went to with Susanna, the one aiming on reducing the number of inpatient harms for patients with diabetes, we were able to identify a nursing document that every single patient that's admitted to hospital, whether they've got diabetes or not, actually has a test. As part of the test, there was a neuropathic assessment and a vascular assessment. Although it was a very simple assessment, it was still there. So we'd identified that when this document became electronic, that if they put diabetes into one of the at-risk factors, they would have to follow the full document and do the assessment. If the diabetes wasn't in that document, they could bypass the full assessment and then still not have the assessment. At that time, there was still no way of identifying all the patients with diabetes in the hospital. So this document was actually copyrighted to a different organisation. So with the help of our EPR, they recognised that adding the one word diabetes didn't change the flow. So with the copyright holder's permission, We added the word diabetes where we say on this purpose T, and we also added an icon on which the pathway popped up, so that every patient that was being assessed could see the pathway to where it was referred to. Further down the document, where there's the vascular assessment, there's another icon where the pathway also pops up. At the end of the document, there's a risk factor and whether you want to refer to podiatry or TVN. And if they click on the podiatry referral, this automatically populates the referral, and there's only a few details to be added from the nurse. That then goes automatically to the inbox of the inpatient podiatry team. So with the results of this, what we did, though the screening, we'd audited the screening before because Aqua collected the data. The screening across the 4 sites went from 37% with a range 33 to 43 up to 91% with an 87 to 95% range. And I know a couple of the months at one of the hospitals actually scored 100% of the ones tested. The diabetic foot referrals increased over the period of time. So this was 2019, and we collected data for the whole year. The diabetic foot referrals increased by 16% in 1 year, and 80% of those were seen within 24 hours of the referral. Of the ones that we didn't see within the 24 hours, 14% of the total were received over the weekend. The hospital-acquired pressure ulcers to the foot patients with diabetes reduced by 57%. We'd audited this directly before the change of documents and again after 12 months, and we had actually been auditing that ongoing. We're not going to claim that this has done this on its own. Like I said, it was part of a pressure ulcer quality improvement collaboration. Now, we'd only collected data on diabetes patients historically from 2012. What we'd noticed from this data, and because we were also getting the referrals for other foot ulcers that didn't have diabetes, that 35% of the total number of patients referred actually were non-diabetes patients. Now, we do have a vascular unit, and the majority of these were identified as being vascular patients. So our discussions and conclusions, of which there are various, is that prior to 2019, the data with 35% that shows that didn't have diabetes, it actually supports our own vascular girth report at the Trust, which had recommended that we develop and provide similar services to the diabetic foot ulcer services. And I'm sure there's other people on here that actually feel the same way, but it just adds some data to actually qualify that. The number of patients not seen within 24 hours, because it's 14%, it kind of equates to a full day, which means we should probably provide some kind of weekend service provision at an acute trust, and that the guidance can be achieved at scale, replicated across multiple sites with minimal additional resource, and any additional resource can be then put into the educating regarding the assessments and treatments and directly against the treatment of these patients. I would say that we actually did go around and do a programme of education, not just to the nurses, but to the junior doctors on their first day that they come in. We now have a programme of education that we join with the TVNs with the link nurses, and we join on multiple education programmes to ensure that the forms are being filled in properly, that they know why that they've got to be filled in properly, and that we did engage with all the staff at the same time. And I think by all working together in a collaborative way, multiple different professions, we can actually make a finite resource go quite a long way and actually be clinically effective and cost effective at the same time. And that's actually probably it, really, if there's any questions.
That's really interesting. Thank you, Paula. Amazing what the addition of one button with the word is on can make. It's extraordinary. I've had a question from Caroline Harveth, who says, what software did you use? How did you get this initiated, and how long did it take?
Overall, it took quite a long time, because obviously we started with the pathway in 2012, probably from about 2015 when they identified something, trying to get the right people engaged. It escalated and we managed to get that completed with the RCPQI project, because the trust were then committed to doing something about that, and that finished it off. The software, I'm not quite sure, it's on Evolve. So it's now a hospital trust electronic system. And obviously the Purpose T is copyrighted to a different organisation that goes onto our Evolve.
Lovely. I think that's a lesson for us all, actually, is if we can include these things in quality improvement, then actually that gives us some leverage to make sure that they happen.
Perseverance as well, and actually thinking, I know this will work if they let us do it. And I think the results do speak for themselves, and the ones that come through, that it does work. You've just got to have a bit of faith sometimes that it will.
And I think that is a real, really helpful tool as well for things like NADIA. So the National Inpatient Diabetes Audit, where I know that a lot of trusts are struggling even to get to the 40% that we're after for. So they're amazing results, and that's certainly something that hopefully people can take away and replicate elsewhere.
Okay,
Well, thank you very much. So next we have a panel discussion, and I'm going to hand over to Emma Hardy MP. Emma is the chair of the APPG on vascular and venous disease, and has served as the Labour Member of Parliament for Kingston upon Hull West and Hessel since 2017. And thank you very much for chairing this session.
Thank you, everyone. And thanks so much for inviting me to be part of this. I have to tell you from the beginning, there's going to be a poll coming up on the right-hand side for you to vote on, which will be at the beginning and at the end of this discussion. So look out for it. We're having a little bit of audience participation during this session, which is great. As mentioned, I'm the chair of the All-Party Parliamentary Group for Vascular and Venous Disease. And I got involved with it not because I have a medical background. I don't. My background's education, but because of the huge health inequalities for the area which I represent. And I have to say, I found being involved in this really fascinating. And I do want to start just by saying thank you to each and every one of you for the work you're doing, particularly in these incredibly challenging times. But panel discussion. So the discussion is on how can we make it possible for multidisciplinary foot teams to see patients with and without diabetes, to treat their foot wounds and reduce non-traumatic amputations. And I'm really delighted that to discuss this topic, we are joined by Mr. Ahmad, who is a consultant vascular surgeon at Manchester University Foundation Trust, Deputy Chief Clinical Information Officer and Director of Manchester Amputation Reduction Strategy and Greater Manchester Aneurysm Screening Programme. Wow, that's an even longer job title than I think Angela Rayner has. And Professor Edmonds, who's a consultant physician at King's College Hospital in London with a special responsibility for care of the diabetic foot. He developed one of the first multidisciplinary diabetic foot clinics in 1918. I'm really looking forward to what both of you have to say. So welcome and thank you for joining us. And I think we're starting with Mr. Ahmad. Welcome.
I think we're starting with the Prof first.
Yeah.
Apologies.
Sorry.
Thanks. Thank you very much, Emma. And it's great to be here. At the outset, I want to say that the benefits of the multidisciplinary diabetes foot team in the widest sense should be available to all who need it, including to people with and without diabetes. The important question is how do we achieve this? And at the same time, maintain high standards of foot care for both people with and without diabetes. Next slide, please. So before we ask the diabetes MDFT to adapt and accommodate to take people both with and without diabetes, we need to ask, and this is in my first talk, why do they exist? What do they achieve? What are the diabetes MDFTs having to cope with? Do they have the capacity in terms of personnel to extend to non-diabetes? And in the second talk, how we can go forward. Next, please. So why do they exist? Well, the diabetic foot is complex with 5 different types. So you've got the neuropathic ulcerated foot, the Charcot foot, and in the ischemic foot, the mild ischemic, neuroischemic foot, the critically ischemic foot, and the acutely ischemic foot. And each of these 5 subdivisions have specific stages in the natural history. Okay, and the next slide will show the natural history. So I'm going to whiz through this. We'll take the neuropathic. This develops an ulcer, develops infection, and then develops infective necrosis. The next one is the Charcot, which will develop bone and joint problems, deformity, ulceration, and infection, and a necrosis. Next one is the neuroischemic, where again we get ulceration, infection, and infective necrosis, this time with ischemia. Next one is the critically ischemic with severe ischemia that leads to tissue ischemia and then digital gangrene. And the final one is the acute ischemic, where we have a sudden reduction of blood supply, which leads to gangrene. So this is a picture of chaos, and the foot is out of control. And the only way you can get control, next slide, and to avoid amputation is to get control over the wound, the mechanics, the vascular aspects, infection, metabolic, and education. And no single discipline can do this. And the next team, the podiatrist, surgeon, radiologist, nurse, orthotist, and diabetologist. Next slide. So what do they achieve? And in 2 recent systematic reviews, there's good evidence for the positive impact. Healthcare system can expect a 39 to 56% reduction in amputation rate, and multidisciplinary teams reduced major amputations in 94% of studies. Next slide, please. So what are the MDFTs having to cope with at the present? Diabetes UK data shows that there are between 70,000 and 90,000 of people living with diabetes in the UK with a foot ulcer in any given week. And we know from Roger Pecorara's work in the USA, pathways to diabetic limb amputation, that 84% of amputations follow on from an ulcer. Okay, next slide. And also in England, they follow on. So between 2016 and 2019, there were 7,809 major amputations, 20,973 minor amputations, 184 amputations per week, 26 per day, 1 per hour. So since this meeting from 12 o'clock, there's been 4 amputations. Next slide. And you can express it in a different way, a number per 10,000 patients with diabetes. And you can see on the y-axis, this is about 8.3, 8.2. And this figure has been constant for the last 8 years. It hasn't gone up, but it hasn't gone down. Next slide, please. And if you take CCG data, there is a 7-fold countrywide variation in the major amputation rate. We heard earlier this afternoon that if you now take STP data, there is a 3-fold amputation rate. Next slide. But whatever, there's a postcode lottery. And CCG data says a person with diabetes may be 7 times more likely to lose their leg in one part of England than compared with a patient in another part. And this principle also applies to people without diabetes. Okay, next slide. This is partly related to the availability of MDFTs, which has been mentioned earlier. And if you look at the top line, 2010, there were 62% of trusts had an MDFT. In 2019, 82% had, and that goes along with the data we heard earlier. Okay, next slide. And certainly now, there is the National Diabetes Treatment and Care Transformation Fund, promoted, as we've heard, by Professor John Valabji, funding to reduce amputations through improved provision and improved timeliness of referrals from primary care. And this is a very important point. Next slide. And this is also complemented by the GIRF program, where with Jerry Raymond of Parsakar, where number 14, all trusts must have a dedicated multidisciplinary foot service. Next slide. So, okay, we're going to go for more MDFTs, hopefully, but do we have sufficient number of podiatrists? Podiatry was particularly affected by the 2017 reforms, resulted in a decline in recruitment of students, mainly because the bursary funding was withdrawn, and this had originally provided full fees for podiatry training. Okay, next slide. The National Diabetes Transformation Fund will provide more posts for MDT care, but the podiatry workforce can only be maintained by reversing the decline in podiatry student numbers. Next slide. Now we've had a new grant of 6,000 for podiatry and a possible further 2,000. But Podiatry Now Journal has asked the question, is cash the crisis cure-all? So my final slide for this part 1 talk is by conclusion, it's slightly paradoxical. We've got to ask the question, have we got control of diabetes foot disease in the UK? We're thinking of taking more patients on. So what is your answer? Possibly, but only just. I guess if you ask the people who've been amputated today, you might get a different answer. So how are we to accommodate influx of non-diabetic ischemic patients into the MDFT? Well, stay tuned, and with the acknowledgement to Blackadder, I will tell you about a cunning plan.
Thank you so much. I look forward to the cunning plan that's going to come up. And as always, I find those images so shocking, and it reminds us why we're all here and that we're all trying to improve lives. Now, I've got this right now. It is welcome, Mr. Ahmed, who's going to now speak to us. Thank you so much for joining us.
Lovely. Well, thank you for having me. Just to avoid technical issues, what I've done is record a short presentation because I'm on call today as well. So just in case, so what I'm going to ask the team to do is just to play that video, and that will hopefully be my presentation, and then I'll come in live afterwards.
Thank you. Brilliant.
Hi, my name's Nasir Ahmad and I'm a vascular surgeon based in Manchester. I'm also the lead for the MARS project, the Manchester Amputation Reduction Strategy, and the lead for the Greater Manchester Aneurysm Screening Programme. I would like to begin by thanking the English Diabetes Foot Network for inviting me, and also to Prof for engaging in a debate and developing a style of debate which we hope will take off in the future. Both Prof and I agree on what the problem is. We know that the solution is needed to the inequality. The question is, how do we do it? And so the normal cut and thrust of debate will not be here. We're not going to be having a go at each other's characters and all that kind of stuff. It's actually about the issue and how we can move the issue forward. So what's my position on many of the arguments that diabetologists have? Well, the fact that diabetes increases the risk of a foot ulcer, absolutely agree with that. Diabetes increases the risk of an amputation, I agree with that. Diabetic foot clinics improve both of these, absolutely agree with that. The fact that diabetic foot clinic care is not standard across the country and the quality of these clinics vary, I fully agree with that as well. Now, moving things on, any change to a clinic must not compromise care for people with diabetes. Absolutely agree with that. And finally, if you're going to change anything with foot clinics, it's got to be accompanied by appropriate resource. Right? So I agree with all that. So let's define the problem. Firstly, how many ulcers are there in the community? Well, we know that the population of diabetes is about 10%, and of those, about 10% have an ulcer. So here's a population of 100 people, 10% have diabetes. Of those 10%, 10% have an ulcer, and therefore that's one person. Of the remaining population, the risk of an ulcer is 10 times less. Therefore, it's 1% of 90%, which is also one person. And this is the crux of the argument. The risk of an ulcer and an amputation is much lower if you do not have diabetes. But the number of people with a non-diabetic foot ulcer and also of amputation is about the same. Now, what do I mean by an amputation? Well, there are two types of amputation. Anything above the ankle is classed as a major amputation, and anything below the ankle is classed as a minor amputation. Now, the proportion of these amputations in diabetic and non-diabetic is quite interesting. Of major amputations, about half are in people with diabetes and half are in people that do not have diabetes. When it comes to minor amputations, it's about 70-30. So let's look at the cost of these amputations. Now, across Greater Manchester, there are 10 CCGs, and we looked at the cost of amputations across over a 5-year period. So what the average cost per CCG, and what you find is that amputations cost about £500,000 per CCG, and of that, the split is approximately 60-40 for people with and without diabetes. It's not cheap. Major amputations, about £300,000. It's a 50-50 split between those with and without diabetes. When it comes to minor amputations, it's about an 80-20 split. And what we find is that the cost for major amputation is the same, and cost for minor amputations, more minor amputations are done in the population with diabetes, and overall the cost is slightly more in that population. But what's important is that the cost in non-diabetes is extremely significant. It's not negligible. It's a real amount of money. But it's not just about diabetic and non-diabetic foot ulcers, even though that problem is about the same. Let's look at leg ulcers and let's look at lymphedema. Leg ulcer is about 3 times more. And the cost across this population, we know it's about £500,000 for amputations. But if you look at lymphedema, foot ulcers and leg ulcers, It's a huge amount more. Leg ulcer cost is 3 times more that of amputations. So finally, the argument is this: it's not just about diabetic ulcers. It's about non-diabetic ulcers, and it's about leg ulcers, and it's about lymphedema. It's about all ulcers and all amputations. Now, the arguments that I've presented to you, they all need to line up when it comes to changing diabetic foot clinics. And once you get everybody to agree on what the issue is, and you bring all the arguments, at some point the system will say, let's change things. And then it's a question of how do you do it? And it's about system change. Once you change the system, that will then affect diabetic foot clinics. So I'm going to end this part of my presentation with a video. This video will describe what we are doing in Manchester. And in the second half, I'll talk about the sort of things that we've done to start this journey. And it's a long journey. Thank you.
Rows of houses all bearing down on me. I can feel them, your hands touching me. All these things into position, all these things are what you slow. This machine will not communicate these thoughts and the strain I am under. Reach out for a circle before we are going I can feel them, can see its beating eyes. All these things into position, all these things are what is close.
I'm back. Thank you so much for that. That was a really interesting presentation, and who doesn't enjoy a bit of Radiohead on a Friday afternoon as well? So that was fantastic. Some questions are coming in on the chat, so I encourage people watching to put the questions in there, which I'll be asking both doctors now. And there's also the poll as well. So if you have a look at the poll, if you haven't had a chance to vote, there is a poll going on, which is: this house believes that MDFT should see all patients with foot wounds to reduce non-traumatic amputation. So you can vote for or against in there. I'm going to go back to the questions. The first one that's come in is from Ruth Cox. She said, how does service commissioning inequalities across the UK affect this? How do we develop our newly qualified colleagues to the specialist skills required to working in these settings? And I'll start with the professor, and then I'll move on to Mr. Ahmad. So would you like to take that question first?
Yeah, I think we have to make it clear that there are predisposing factors. We know that gangrene is a disease of the poor, and work in Glasgow has linked disease of the foot to the most deprived areas in Glasgow with geospatial work. So we've got to work out the funding according to the geographical location and to the deprivation of the patient. So those are two important principles which commissioners have to take on board.
Thank you. Mr. Ahmad?
Well, I guess when it comes to commissioners, they have several agendas. One of them is how to spend the money they've got correctly and equitably to their patients. And one of the big drivers for what they do is about removing inequality. And to remove inequality, you've got to work out how the system is set up and to make sure that the services that you have are have a level playing field in terms of their provision, access, and outcome. And to make those services work, they've got to be staffed properly by the right sort of people with the right skills. Now, the College of Podiatry have a set of skill sets that people need from the I forget what the document is called now, but it's the like a skill set for the way podiatrists work, and it grades what those skills should be, from band 3, band 4, right up to band 6, band 7. And with the new Health Education England document coming out, you've got what the band 8s should be doing as well. So it's all documented out there what the skill sets should be. And once those people come out, it's about getting the university education right so they understand the environment they're going into. And then as professionals, we have to represent our patients to the commissioners and to those service leads and present those arguments around inequality, around finance, and around what the services should be. And at some point, there will be a tipping point where people will finally get it. And the good thing about having the term amputation, that people kind of understand what an amputation is. Understanding what an ulcer is for a non-clinician is a bit difficult and a bit hard, but everybody understands amputations. And if you start at that point, you can start to move forward.
Thank you. A few more questions come in, but we might only have time for one. So Julie Taylor has asked, will the expectation for integrated care in the community help reduce amputations and costs of lower limb ulcer care? And this time I'll start with Mr. Ahmed and then the professor.
The answer to that question is yes. The second half of my presentation shows some of the changes that we've made in one of our services and how that has impacted on hospital costs of amputations and ulcer care. So the answer is yes. And many of the patients in hospital start off in the community. So you've got to get the community care right so they don't end up going into hospital. But that holistic system flow is absolutely crucial to understanding the patient pathway.
Yeah, I agree. Integration is crucial. Integration medically, socially, with community, with hospital. I think one of the positive things from COVID has been community and hospital integrating well, and I think that can only improve foot care.
Thank you. And we've had another question from Martin Fox. It says, Mike and Naz, can we pool existing NHS resources in podiatry, nursing, vascular into an integrated clinically led lower limb protection service model to achieve better outcomes? And I'll start with the professor this time. Thank you.
Yeah, great idea, Martin. As always, you're full of great ideas. And because the funding has got to support a pathway, a foot service. I mean, Nazir will say the vascular surgery gets funded as a unit, but diabetic foot care, you link in, as we just heard, podiatry, nurse, orthotics, surgery. I think we've got to fund the whole as a unit.
Mr. Ahmed?
Absolutely. I mean, what's the other option? There's no magic money tree anymore, despite the fact that we were supposed to get more. The £350 million a week we're supposed to get, that's not coming. And so we have to use more. Yeah, exactly. That bus, I'm not sure what that bus is. But I think the Liberal Democrats use that for their party thing. Anyway, forget that. Anyway, so the point is, there is no other option. We have to use the resources that we have better, and we all have to start working together, and integrating care through protocols is the way to go. And Martin is actually leading this in North Manchester, where they've got the lower limb collaborative, where tissue viability and nurses and podiatrists are working together in the community with a single protocol that works well with vascular. We've repeated that in another part of Manchester called Salford, which the next presentation we'll be speaking about more with Adam and Sam. It is being done. It works, and it needs to be spread out more.
Thank you so much for that. And that's the end of the questions that I have, and it's been a real pleasure to see you both and to take part in this. And I think I'm handing back over to, I'm just going to quickly check over to Mike. So thank you, and hope to see you again at another event in the future.
Okay, thank you. Fine. Could I have the next slide? This is the way forward. Next slide. It's got to be practical, feasible, and workable. Next, please. So I'm going to be realistic and base this at the code face and assume there's no more resources. So I want you to consider a hypothetical MDFT and its clinic slots for a day. We've got 30 treatment slots. In future, perhaps 10 of these will go to non-diabetes people. That will leave 20 slots for people with diabetes. How will the 10 other people with diabetes be managed? Next slide. Okay. We could make it 40 slots in the day, longer working day. We're going to add in ischemic patients with little neuropathy. They'll take longer, and the clinic may finish late, even 7 to 8 o'clock, because we've got the same number of staff. So this is not realistic. Next slide. We could transfer the people to the community. However, they will have no more staff. The community personnel have been great in COVID-19, but recently reports of exhaustion and feeling put upon have been coming through. They can be trained in the care of the complex ischemic ulcerated patient, but is it fair to ask for such care in the community? Next slide. So what is to be done? Asked Lenin. More resources would be the ideal solution, but unlikely in the present situation. So this is the crux of the plan. In order to create new available patient slots, we need to have fewer patients actually needing management slots in the MDFT. So we've got to simply reduce the quantity of disease in the diabetic foot. So how do we do that? Next slide. I've showed you this. Now, feet in stages 3, 4, and 5 constitute the foot clinic. In 3, it's often the late one. If we could get the presentation earlier, particularly in stage 3, then we should be able to cut down the number 4s and the 5s. Next slide. In a service evaluation of our foot clinic, this was done by Chris Manu, when we compared the time needed for treatment in the clinic between regular new patient formal referrals and emergency new referrals, new patients with a formal referral needed a longer treatment time in the clinic than self-emergency new patients. And you can see this on the graph. If you look at the far right-hand column, you can see that over 60% of the regular new patient referrals were present in the clinic over 4 hours. That's going for X-ray and various other things, compared with the 18% in the emergency new referrals. Essentially, the emergency new self referrals were likely to have a less advanced clinical stage, and with our open access policy, increasing patients' empowerment to present early, the complexity was reduced. Next slide. And this is borne out by the NDFA. I want you to look at the first row at the top and the third row coming down. And you will see that the self-referred patient, 64% were less severe ulcers compared with 35 severe. And that's compared with the 3 to 13 day referral when it was 53 to 46.7. Next slide. So there's a direct relationship between the time that elapses from first presentation to a healthcare professional and being assessed by a specialist clinician, and the severity of the ulcer at presentation to that specialist clinician. Longer the time, the more likely the ulcer is to be judged severe. Next slide. And the severe ulcer is linked with worse outcomes. Lower rates of fee, higher rates of major amputation, higher risk of death. However, with early referral, ulcers will be less severe. Next slide. And further data confirms that. Just simply look at the blue line at the SIMBADs 0 to 2, and the far end, the SIMBADs 3+. And there were 59.9% alive and ulcer free in the less severe ulcers at 12 weeks, compared with 34.9 in the severe ulcers. Next slide. And economically, Marion Kerr looked at 2 patient groups. Group A was essentially SIMBAD score of less than 2, and Group B was SIMBAD 3 or more. And she showed, next slide, that the cost for the Group A was, as you see, 125 to 157 million, and the Group B's SIMBAD score up to 503 and 628. So there's a bigger cost as well. Next slide. So what causes these delays? And Nicholson, actually, who was a vascular surgeon, did a systematic review of delays in the management of chronic limb-threatening ischemia and foot ulceration in people living with diabetes. So there was a poor symptom recognition by the patient, inaccurate healthcare assessment by the HCP, and difficulties in accessing specialized services. So what can we do about what are the factors? And next slide. And I belong to the ideal group. I mentioned this at Diabetes UK, but I hope you'll bear with me. This is a multidisciplinary team of specialist team, and we produced a position paper called Act Now, Diabetes and Foot Care Assessment and Referral. Next slide. Central to this position paper was the fundamental perception that time is tissue, and we've got to get patients more quickly to the clinic. It's fine increasing the MDFTs across the country, but if the patients don't get there, they're not going to benefit. Okay, so in response to this, the acronym Act Now was devised, and most of it was constructed by a person with diabetes. It was to help recognize the warning signs that might lead to amputation, and the identification of such signs should give people with diabetes permission and confidence to seek help, either by self-referral or rapid referral by an HCP. Next slide, please. So we have this Act Now, and A is for accident, C is for changing color, C is for temperature change, N is for new pain, and O is for oozing, and W is for wound. And it can be put in an infogram, as on the next slide, which can go onto a credit card or a key ring. So it's Act Now, accident, change, temperature, new pain, oozing, and wound. Next slide. An Act Now tool has been devised to include the infogram and also this checklist, which goes through the accident, change, temperature. This is for the healthcare professional, because the healthcare profession has got to be aware of this Act Now and act also on it. And carrying on, next slide, there's the new pain, oozing, wound, and this checklist can be used as a referral document. Okay, next slide. So the plan is to extend the Act Now acronym to an Act Now campaign. You will all be familiar with the Act Fast campaign, which informs the public of the early warning signs of a stroke. It happened a few years ago. It's been brought back in COVID because patients weren't presenting with stroke. And the next slide takes this further on by extrapolation. Like stroke, diabetes foot is time sensitive and can lead to rapid destruction of tissue. And the next slide shows how the message has been animated, and hopefully it will play about 60 seconds. thanks to Ideal and Orange Juice Communications. So the plan would make this an Act Now campaign to make it available as widely as possible to diabetes and the non-diabetes population. Possibly make the animation into a TV advert and play it in the middle of Ennerdale Farm and Coronation Street. Extend it to the Vascular Society, the National Wound Care Strategy Programme, and to private and public bodies. Next slide shows the endorsements we've got so far: Diabetes UK, Royal College of Podiatry, PCDS, FDUK, the Welsh Network, DFoot, English Diabetes, and JDRF. So finally, the next slide concludes that given increased space, both time and physically, we can bring care of the diabetic foot and the non-diabetic ischemic foot closer. Vascular expertise should come with the vascular patient and forge close links between the MDFT and the Vascular Society. This should improve the outlook of patients with either types of foot and reduce the total number of amputations and this unacceptable postcode lottery of amputations. Okay, over to you, Naz.
Lovely. I think Richard's coming back in. For my second half, I've got a video that with the same garden gnome next to me. So we'll play that shortly, and then we'll take questions afterwards.
You know, how do you affect change? I think the key arguments for system change, and that system change will then affect foot clinics, is you've got to get the arguments right. It's not just about starting with, well, it's the obvious thing to do, it's the right thing to do. We all know that, but you've got to build the argument in terms of the inequality, the evidence, and most importantly, the finance. You've got to get that argument absolutely. Feed a lot of this data through to finance takes time. But what we found is over the last 2 or 3 years, the cost per amputation in Salford is lower than in a neighbouring CCG. So the table below shows that the cost per amputation is about £8,500 overall across Greater Manchester. It's higher in Manchester CCG and much lower in Salford CCG. And Salford is where many of these, the Tier 3 clinic has been started. And the next presentation will be talking about this as well. But the major amputations is the same, regardless of what the community clinic is like. But the real difference appears to be in minor amputations. The cost of a minor amputation, if you do not have diabetes, is much lower than a diabetes population. And I think that is probably related to better care for these patients in the community. And then, you know, change is always going to be hard. It's never easy. But you just need a few dedicated people, and you just do what's easy. And then you do the next thing that's easy. And then you do the next thing that's easy. You can't tackle it all. You just do what you can do. We've managed to do a lot of this in Salford, and a lot of it was helped with the opportunities created by the pandemic. We now need to embed a lot of these changes. But what I am proud to say is that we have achieved a lot of the strategic aims of the National Wound Care Strategy in our clinic, and all the people that benefit from it. Our main clinic serves a population of about 280,000 people. And we've managed to effect positive change by just doing a few things differently. There's a long way to go, but we're well up for it. Thank you.
Begging you, put your loving hand out, baby. Begging you, put your loving hand out, darling. Begging you, put your loving hand out, baby. Begging you, put your loving hand out, darling. Begging you, put your loving hand out, baby. Begging you, put your loving hand out, darling. Begging you, put your loving hand out, baby. Begging you, put your loving hand out, darling. Begging you, put your loving hand out, baby. Begging you, put your loving hand out, darling.
And that's essentially my presentation. The key to changing MDFTs to incorporate everybody is you've got to bring all the resources that you have within a city to make it happen. You can't just change one particular part of it, because you've got to convince everybody within the system that needs to make that change happen. And change is all about the aggregation of marginal gains. There's no one big thing that's going to change. It's about 1,000 little things. And to understand what those 1,000 little things are, you've got to get everybody in a room, start talking to one another, and therefore you understand the whole process and all the steps. And you've got to get the finance guys in the room, you've got to get the director of strategy in the room, you've got to get all the clinical guys in the room, as well as all the podiatrists, the AHP leads, and everybody else in the room, just to understand what the problem is. Everybody's on the same page. And then once you start that and you progress the arguments, at some point there will be a tipping point and people will come around to the argument. It's taken 3 years just to get the argument right. We've now begun that process, and we've started it in those areas where it's easy to do. We've done it in Salford, and now with the help of the National Wound Care Strategy, Manchester is one of the first tranche implementation sites. We've got some more resource to do it over a larger area, and that's building on the strength that we've already got in Manchester, particularly around Martin Fox did his question earlier on about the work he's doing in the Low Limb Collaborative in North Manchester. That model is being used, and we've developed a business case to use that across the rest of Manchester. we already know what to do. That's not the hard bit. It's about getting the funding right to make it available for everybody, and that's where the challenge is. Thank you.
Lovely. Thank you both very much. I don't know if I appear to have frozen on the screen, but I will keep talking. I have just a couple of questions. One from Scott McNabb, who says, will emerging ICS and PCN working help in bringing skill sets typically held by secondary care into primary care settings? And I'll ask that of Mr. Ahmed.
Absolutely. I mean, the key thing about integrated care is you've got to coordinate the hospital and the community protocols, and people just need to start talking together and singing from the same hymn sheet. And it's absolutely about people in the hospital working much closer with the community, and vice versa as well. And also, I mean, one of the things we have in my clinic is that we've got one podiatry team that works in the hospital and the community, and the podiatrists rotate round from the MDT clinic into the tier 1 and tier 2 clinics. And also same with the district nurses, and also the tissue viability as well. You've got to get that expertise and that confidence within the system to manage wounds outside of a comfortable setting.
And I'll ask that same question to Prof. Edmonds, if I may.
Well, no, I absolutely agree. And the integration principle, I think, was fundamental to the MDT clinic. And it's although one person may have to take total responsibility, it's like a game. You may have a captain. In playing cricket, you need a batsman, you need a wicket fielders, and that's the only way you're going to win games, and that's the only way you're going to win through on the diabetic foot.
Lovely, thank you very much. And just a very quick question to Mr. Ahmed. I think this is going to be, is it possible to get copies of your referral pathways to try and encourage other CCGs to try and adopt the same approach and prevent fewer inappropriate referrals into vascular clinics? And that question from Jacqueline Force.
The answer to the question is yes. We're not making them publicly available just yet. They're going to get ratified by various national bodies, because one thing I'm particularly keen on is getting our local pathways and guidelines ratified by national bodies, so that they need to be able to stand up to national scrutiny. And so I just want that little step to be, we're quite happy with them. I mean, they fulfill all the nice guidelines and all the other guidance that they need to, but I just want to get them rubber stamped before I make them available publicly. But if people just want to email me directly, I'm happy just to share those.
That's wonderful. Thank you ever so much, both of you, and for a very interesting discussion. And I'm sure this debate will continue for some time. Thank you both.
Thank you.
Thank you.
We now move on to a delegate address from Dermatonics regarding hospital-acquired ulcers protocol.
According to the National Diabetic Foot Audit, for every 100 people with diabetes admitted to hospital without a foot ulcer, between 1 and 2 will acquire an ulcer during their stay. Sadly, 42% of diabetes patients who develop a foot ulcer will die within 5 years. Numerous initiatives and programs have been launched to combat this, including pressure mattresses, inflatable leg splints, and a variety of other equipment. Today, we present a very simple protocol with a proven track record. It requires very little training and minimal expenditure. One of the risk factors in the development of diabetic foot ulcers is callus. By removing callus, the risk of a person with diabetes developing a foot ulcer is significantly reduced. Each high-risk patient has their feet examined once a day, and a sachet of Dermatonics Once Heal Balm is applied to both feet. Dermatonics Once Heal Balm has an active ingredient of 25% urea, making it keratolytic. This means it safely and effectively removes hard skin. It also contains dimethicone and beeswax, which help reduce transepidermal water loss. Dermatonics Heal Balm is proven as a once-a-day regime, and its efficacy was documented in the Diabetic Foot Journal article published April 2020, entitled A Clinical Review of Dermatonics Once Heal Balm to Assess its Impact on Callus Associated with Neuropathy, and on podiatry workloads. The conclusion of this paper was that Dermatonics Once Heel Balm can be extremely successful in the management and reduction of callus, a known risk factor in first and subsequent foot ulceration. On the selected hospital ward, a named person, be it a nurse or healthcare assistant, is given time to see each high-risk patient. The HCA or nurse examines the feet, including both heels of each patient. To ensure quantitative measurement of skin condition, we advise the examiner uses the skin scale. This scale was developed by Dr. Matthew Young, consultant physician, and Mr. Mike Townsend, a podiatrist who, at the time, sat on the all-party parliamentary group for the reduction of lower limb amputations. The skin scale has since been validated by over 200 podiatrists. Simply compare the patient's heels to the photographs and note which image is closest to the patient's skin, and note the level 1, 2, 3, or 4. During this time, the Ipswich touch test may be used to test the patient's sensation. Then each patient has Once Heel Balm applied to their heels. The Once Heel Balm is presented in a 2 milliliter sachet, 1 sachet per patient. By using a sachet, there's no danger of cross-contamination between patients, and the dose is the same for each application, in case there's a change of personnel. This protocol was first used in Ipswich Hospital under Professor Jerry Raymond, MBE, Head of Service at the Diabetes and Endocrine Centre, the Diabetic Foot Clinic, and National Inpatient Programme Lead. Ipswich Hospital chose Dermatonics Once Heel Balm as it had the best results of the many creams tested for inclusion in the protocol. The protocol, commissioned by Diabetes UK, showed a reduction of hospital-acquired foot ulcers of some 2/3. It was estimated the protocol helped prevent some 19 ulcers a year, with a financial saving of £214,000. Since then, in a large Midlands hospital, the protocol was used in a trauma and orthopaedics ward, which had previously experienced a high level of pressure ulcers each month. During the trial period, there were no ulcers in 7 out of 8 months. In this instance, improved results were achieved by switching from a barrier cream to Dermatonics Once Heel Balm. The protocol has since been adopted by Northern Devon Podiatry Department for use in a number of cottage hospitals. At Dermatonics, we're happy to help boards achieve a reduction in hospital-acquired foot ulcers. For a 3-month trial period, we can provide the sachets free of charge. Once the protocol is formally adopted, the sachets are provided at a minimal cost of 20 pence each. On average, each foot ulcer costs £14,600 to treat. On average, a person with diabetes spends 8 days in hospital when admitted. The total cost per patient of the inpatient Footcare protocol is £1.60 per stay. This protocol, therefore, is a win-win. It saves money for the NHS, and by reducing ulcers, it also saves lives. To register your interest in running a trial, please contact me at gareth@dermatonics.co.uk. Thank you for listening.
Lovely. I appear to have a frozen screen, unfortunately, but I will continue talking. And on to our last presentation, which is a Salford case study, creating an integrated model of care. Unfortunately, Adam Robinson and Samantha Haycox can't be with us and have pre-recorded this, so there will be no Q&A at the end of this session. Sam is a consultant podiatrist and professional lead for Salford's integrated podiatry team. She's a fellow of the Royal College of Podiatry and the Royal College of Physicians and Surgeons of Glasgow. Adam is a consultant in diabetes and endocrinology, responsible for the medical input to the Multidisciplinary Foot Clinic service. He's Vice Chair of the Integrated Care Division at Salford Royal Foundation Trust.
Thank you, Richard, for that introduction, and thank you to the EDFN for inviting us today to discuss our integrated model of care. So briefly, we're going to look at what our service is, why and how we set up the service, what were the main enablers and obstructions, and what were our outcomes. So Salford is situated to the west of Manchester in the north west of England. We have a population of approximately 245,000 people, and 16,000, or about 6.5% of the population, have diabetes. We are listed as the 18th most deprived area in the UK, and 30% of our population actually live within a deprived area. Geographically, the podiatry team is split into 3 neighbourhoods. In each of these 3 neighbourhoods, there is a skill mix of Band 7, Band 6 and Band 5. We also have 9 community clinics, 4 of these being gateways, where there are other specialist areas available, such as physiotherapy and children's services. And our acute site is marked with a star on the map in the Eccles area. So in Salford, for clarity, our Footcare service, the whole team is actually part of our MDT. So the MDT clinic isn't seen in isolation, but part of our integrated Footcare team, and it stretches across the traditional healthcare boundaries, working across both primary and secondary care. We have formalised and structured pathways which have been made within the multidisciplinary, multi-centred care, shared care team, so patients can move seamlessly across the community and acute systems. This allows them to be with the same podiatrist as well for seamless care. So integrated care and the sharing of appropriate information in the management of these vulnerable patients is absolutely key to provide us with the optimum management of them. It's important to note as well that in Salford, we will see any person with a foot problem. We're not just seeing patients with diabetes. We will see the non-diabetic population too. So the main foot protection team, our MDT is reliant on our members of the foot protection team. Obviously, they are preventing problems, recognising when problems occur, and know when they need further investigation and referring them on promptly. So they're providing a regular surveillance of patients in line with their clinical need, assessing footwear and biomechanical interventions, provision of orthoses, education, tailored education for the patient as well, and direct referral to smoking cessation, dietitian, weight loss management, and obviously continued review of patients with PAD and ensuring that they're on best medical therapy. Patients with diabetes are well controlled and HbA1c. We also run emergency clinics out in the community where anybody with a foot problem can access urgent attention. Our high-risk team consists of Band 7s, and they both have weekly dressing clinics at both the gateways and on our acute site as well. They perform ABPIs and toe pressures, and they're all non-medical prescribers, have excellent knowledge in wound care and advanced wound care products. All are good at offloading and casting. They have excellent communications with the GPs, the district nurses, tissue viability nurses, and obviously within healthcare and with nursing homes and residential care homes. We're very lucky that we have access throughout the week to microbiology, diabetes, vascular and ortho specialists. And also with the event of COVID, for better communication, we have WhatsApp groups, so we have instant access if we need questions or guidance, advice. We've got it all instantly. We also do a lot of combined care with wounds with the district nurses and our tissue viability teams. We've also recently introduced electronic records, and we have a specific wound care assessment tool, which all disciplines involved in the patient's wound can access this document, so everybody knows what the treatment plan is, what dressings are, whether they've had Dopplers done. It also acts as our audit tool as well. We have the NDFA, diabetic foot ulcer audit, built within it, and we also have the Wi-Fi component inbuilt. Also in the community, we run a vascular triage service. This is run in the community. There's direct referrals from the GP. They do Dopplers and ABPIs, toe pressures, pre and post exercise, palpation of abdominal aortas, and then produce tailored management plans for the patients and ensuring they're on best medical therapy, smoking cessation, and then they can directly refer to structured exercise classes for the patients. This service has optimised appropriate referrals to our vascular surgeons, and approximately 5% of the referrals that the vascular triage see are actually referred up to the vascular teams. So each week we have our multidisciplinary foot clinic, which is at the acute site on a Wednesday. We do run high-risk dressing clinics throughout the week at our acute site, and A&E have instant access to appointments if there is anybody who presents there with a foot problem. So our weekly MDT starts at 8:30. We have a verbal review of all our patients that are attending. We start at 9, and then the clinic finishes when it finishes. It always tends to be very busy. We have 5 podiatry chairs, which are treating patients simultaneously. And we have, normally in clinic, we have 3 band 7s and 2 band 6s. This clinic is also used as an education for our lower band graded staff, obviously for their development and education. We have our own separate unshared department. So each week on the clinic, we've got the principal podiatry and biomechanics, consultant podiatrist, consultant physician, consultant vascular surgeon, microbiology, tissue viability, diabetes specialist nurse, and our podiatry assistants. And once a fortnight, we have our consultant orthopaedic surgeon present on clinic, and he also runs a minor surgery list from 8 till 9. And this allows us to refer patients in for toe tenotomies, and he also does tendo Achilles lengthenings. Obviously, during COVID, we've done more virtual reviews in the patient's home, and this is one of my favourite consultations, where we have Louise, our band 7, out in community at the patient's house, and she's also actually with the tissue viability nurse, who isn't actually visible. And then we've got Mr. Ahmed, who's actually in his office in Manchester Royal Hospital, and then we've got Adam, myself, and Matt Allen, our principal podiatrist in biomechanics, and on our acute site at Salford Royal. So we got the MDT consulting in the patient's own home, and the patient then was referred for an appropriate surgical intervention. Additional support to this clinic, we have medical photography. Every Wednesday afternoon, we have our radiology MDT, where we'll discuss all our imaging that we have done. And then as required again through the week, we've got instant access to microbiology advice, diabetes, vascular and ortho. We also, within our electronic records, share the Greater Manchester Care Record. So all GPs link into our system so we can see patients' current medication, and they can see any letters that have been populated from the clinic. We also have a medical inpatient facility. We can ring our EAU department and refer patients who need admitting for IV antibiotics straight away, instead of them having to sit and wait in our A&E department. We also have very close links with our rheumatology department, and we have one podiatrist who works within the rheumatology clinic as well. And more recently, we've now got access to plastics as well. So audit is a very important part of our integrated care team, and one of the most valuable tools in educating the whole of our team is to retrospectively analyse situations that didn't go well. So each year we look at all our major amputations that have happened and look into each case individually and look for any learning outcomes from the situations to see if we can improve our care. And traditionally, this has just been looking at our diabetic population. But for the last couple of years, we've actually looked at our non-diabetic patient major amputations as well to see if there are areas that we can improve on. And now I'm going to pass you over to Adam.
Sam, and I'm just going to go on with the last few slides just to explore and explain how we got to set up our integrated service, and I want to contextualise that with something that you've already heard from earlier in the day from other speakers, and that is that approximately half the patients attending this foot service don't have diabetes. And I think part of this is how we managed to incorporate those patients, if you like, into a more traditional diabetic foot service. So how did we do it? I think you have to say that, as is often the case in the NHS when developing services, no one actually stopped us from doing it. I think that's one of the critical points. And when I spoke to Bob Young, who was my predecessor here, that interestingly was one of the first things he said. I think it's also important to say that there was no grand design to this. This has been an organic process over time as we've added to the service in terms of who's been delivering it. And I'd also point out that we've not actually got to where we wanted to be, and there are things we'd like to further develop and other people we'd like to bring into the service, so that we really do have a comprehensive, if you like, and complete service for our patients. And I'm going to go through how we did it, really with reference to what the enablers were and what the obstructions were. And I fully accept that other people will have developed similar services and perhaps in many ways be ahead of us. And they may not necessarily have had all these enablers, and hopefully won't have had all the obstructions. So this isn't the only way of developing a service, but nevertheless, I'm going to go through some of the things that we feel that made it possible for us to develop our service. So the most single important part of our service is the podiatrists, and I can't overemphasise that. We've gradually expanded the workforce over the years, and really critically, it is one service. There's one management structure. It's the same group. We don't have a community section. We don't have a hospital section. It's one group of people delivering the service across the whole patch. And this is important. So, for example, a multidisciplinary foot clinic podiatrists are the same podiatrists who might be out in the community in a nursing home delivering care, or they might be in the foot protection service delivering a clinic there, or might be part of the vascular assessment service. But it's the same people working through the whole system. And consequently, they have a complete and thorough knowledge of which parts of the system patients need to access, because they know it intimately, and also because they work with the other people delivering the multidisciplinary service. They know them, and communication is relatively easy. The other people, I think it's important, the microbiologists and diabetologists were in fact the original consultants that staffed the clinic, and the microbiologists didn't have another venue to see some of their patients that they were treating with antibiotics. So that was really the first part of the non-diabetic patients attending the clinic, and it grew from there. And I think more recently, now that we've got a resident vascular and orthopaedic surgeons within the clinic, as Sam has alluded to, I think it's important that the individuals that we've been able to get to join us have been very forward-thinking and real clinical champions of their specialty within the multidisciplinary foot clinic service. And I think it can't be underemphasised how important it is to have clinical champions really in as many of the different disciplines as make up your service as possible. Some of the things that have enabled us to do service really seem quite banal and have been very important, and not necessarily something that we planned from the beginning. The most obvious thing is the actual podiatry centre where we deliver our service is our own. It is dedicated only to delivering podiatry services. It's not shared with anybody else. And consequently, we're able to use it as we see fit. And also, as we've expanded, we've been able to just simply add on clinics or expand clinics or lengthen clinics into that space without, if you like, having problems with other people using similar services. It's on the main hospital site, and therefore it's very convenient for radiology, for laboratory support. It's not too far away from our other outpatient clinics run by the rheumatologists and dermatologists, and occasionally when we need their input into clinics, they can come down and see us because we're next door. And lastly, one floor above us is the A&E department and the emergency admissions unit. So the small number of patients that we need to admit from clinic can easily do that. And we have a good relationship with all of those nearby groups, if you like. Job plans have to be flexible for this, and I think the hospital's helped us there as the service has grown and the time that I've needed to put into it. For instance, That's been able to be expanded. But also, when you're supporting a large team of podiatrists out in the community, not all problems come about at the time of your multidisciplinary foot clinic. There has to be flexibility in staff job plans to allow them, if you like, to be accessible through the rest of the week. And it isn't very good at doing that. But there is some flexibility in our job plans to allow us to, if you like, dip in and out when we're required to support the larger team. We have an electronic patient record at Salford, which we've now had for over 10 years. And I think that's actually, it would be absolutely impossible to deliver this service without that. It means that if you're contacted or you speak to a vascular surgeon on a phone line, if you speak to the orthopaedic surgeon up in his clinic, we can all look at the same x-rays, the same pictures, the same laboratory reports, etc., as each other at the same time. And I think that would be impossible with a conventional paper record. At the moment, we're using WhatsApp and Consultant Connect as two other means of communication. And the Consultant Connect is embedded into the EPR service, but we really need something more suitable than WhatsApp for our non-face-to-face patient contacts and for group discussions about patients, which Sam's already alluded to with an example. It's important not all patients need to see all the clinicians in the multidisciplinary foot clinic, and so we're relatively sophisticated in the pool of, if you like, supporting staff are in the back office and come through to see the patients in their podiatry chairs as and when requested to do so. Meanwhile, there's lots of other things that they can be doing, and part of that is facilitated by the electronic patient record system. That means we can be doing other clinical activities, if you like, with patients when we're not necessarily having to see people in the foot clinic. I think it's also important with all the staff that are involved in the clinic is that there is some blurring of professional boundaries. It's inevitable when you're seeing patients together at the same time that you start to learn, if you like, what our colleagues would do in certain situations. I'm afraid we're not able to have everybody there every week. And to some extent, if 80% of the team are there, generally speaking, there's enough knowledge, if you like, about the missing bit that we can generally implement maybe the vascular component of the plan if we've no vascular surgeon that day, possibly with a communication to them, say this is what we've done, and we think it's appropriate, and that can be modified as necessary. I think in terms of recruiting people and also getting the hospital, if you like, to support us, we have had over time some relatively high-profile clinicians involved with a good reputation, and also it has happened that some of those involved with the clinic have had significant management posts within the hospital, and I don't think that's unhelpful when you're trying to expand services. And lastly, I think across the board, there's really a very strong can-do mentality amongst all the different disciplines delivering our service. Obstructions, as ever, getting funding for some posts has been very difficult. I think to an extent we've been quite serendipitous here. For instance, Salford Royal has been nominated as a trauma centre for Greater Manchester, and as part of that we're building a new acute receiving unit with a helipad, etc., for which they required an additional 8 orthopaedic surgeons. And off the back of that, it was relatively easier than it might otherwise have been to ask if we could have an orthopaedic surgeon dedicated to our clinic, for example. The vascular surgery, that has been hard to get funding for, and at the moment it's pretty much running off the back of the fact that by having a vascular surgeon here whilst satelliting from another hospital, we are able to fund that really off the back of the extra surgery that goes through the vascular services at the hospital next door. One of the problems that's come out of COVID is the reversion to block contracts, which is making it much more difficult for us to put forward business cases, because increased clinical activity at the moment isn't rewarded with increased funding. So that's become a bit of a block on some of the developments we have in plan. Other obstruction is different footprints, really, of the different specialties that feed into the multidisciplinary foot clinic service. Some of them have different footprints, and we're unable to see some patients, particularly in the podiatry service, because we're simply not funded, particularly for some of the expensive orthotics, etc., from patients that aren't within our own catchment area. And as ever with most NHS services, we extremely struggle for clerical support. And as the clinics become more complicated with more people delivering the service with different secretarial backup, different clerical service, that's become apparent as a significant problem. And I think the next step might be to have our own specific clerical service. And then lastly, the single thing that vexes us most of all, I think, is the fact that our vascular surgery in Manchester is based on a hub and spoke model. And whilst we are described as a super spoke with a super service, and we do have excellent vascular support, there's no question about that. The problem is when a patient needs a bed in another hospital, as I'm sure you're all familiar with, they're considered to be in a place of safety, really, in our hospital. And if we have one clinical adverse consequence, it's from the fact that our vascular surgery is off-site, and patients have to wait sometimes in a queue to get to those services. What would we like to do next? Well, the icing on the cake, really, we would like to have better relationships with our elderly care colleagues and end-of-life care. A significant portion of patients are elderly and moving towards the end of life. And I think we have in Salford a Salford Care Homes practice, so all patients in care homes in Salford are under one practice, which is based at the hospital. So we have good relationships with them, but we'd like to expand that. We're looking at having shared inpatient beds for vascular orthopaedic and medicine, though that's we're a long way off that at the moment, but we think to have a small number of beds dedicated, probably under the diabetes department, would be helpful. And very recently we've had 3 plastic surgeons appointed at the hospital, and we're looking to get them involved in the clinic. As is often the case with these things, you don't really appreciate what the plastic surgery department can offer a multidisciplinary foot service until you have them there on a regular basis to, if you like, show them what they can do. And they started about 6 months ago in Salford, and already we're starting to see that they could have a significant role in our service. And then just lastly to say that as a result of all this, of expanding our service, particularly into the non-diabetic patients, I just want to point out you can do that without having a negative impact on your outcomes. So I just picked a couple of things off the last National Diabetes Foot Audit, but here you see a proportion of patients admitted to hospital within 6 months of an admission related to diabetic foot disease. You can see on the left our results, and you can see the average for England and Wales, and you can see our readmission rate is 12% for all ulcers versus 21% nationally, and it's lower for both less severe ulcers and for more severe ulcers. So we've done this without having a negative impact on our outcomes. And if you look at alive and ulcer-free data, again, Salford here compared to England and Wales for all ulcers, less severe and severe ulcers, you can see again that our alive and ulcer-free numbers are significantly higher than the national average. So in summary, the development of our service has been organic. It would be dishonest not to say that much of this has been serendipitous. We have an independent facility which has allowed us to expand. We have a sector-wide podiatry service which is absolutely vital in seamlessly connecting the different components. So we've had excellent like-minded clinicians who are all in their way clinical champions. Is it replicable? I think you do need a minimum infrastructure. I think you need a minimum expertise, but I think most of that exists everywhere. And as ever, getting funding is probably the biggest single problem. Thank you for listening.
So thank you to Sam and Adam for that recording. We've really run over time slightly, for which I apologise, and also for the gremlins earlier. However, just to sum up, hopefully from the conference today, we're in a position where we've got some new thoughts and new ideas to take away with us. Some of it has come from COVID-19, where we found new ways of working, many of which we're going to take forwards. I think also the impact of some really straightforward and easy ideas, or easy-ish ideas, that we can use, such as putting a diabetes button onto your IT system. A few people have been asking in the chat about whether this has been recorded or whether this will be available, and I think some of this will be available, so please do look at the EDFN website. And if you haven't signed up, you obviously have an interest, so please come and join in. And finally, I must thank all of our speakers and our poster presenters and those who've had posters in the expo area. I must thank our guest chairs, so Emma Hardy and Professor Jerry Raymond. Also our sponsors, thanks to Ergo and Dermatonics. I'd like to thank the people who've been busily sorting out the gremlins in the background, OJ Communications. So thanks to Ollie, Emily and Laura. I'd also like to thank the Royal College of Podiatry, who support the EDFN, and indeed the whole team in the EDFN who've managed to put this conference together. And finally, I'd like to thank all of you for attending today and making this a very successful meeting. We hope to see you very soon, and I wish you all a very, very pleasant weekend. Goodbye.